They look at the end of the amputation. So he didn't amputate through the bone. He did what we would call a disarticulation.
Disarticulation. I was going to say that. Okay,
Yeah.
so he removed the feet bones from the ankle joint. Is that
Just
right?
cutting through the soft tissue. Yeah.
Yeah. So he's basically like when you rip a leg off of a chicken.
Jesus.
I'm not going
What? Oh, excuse me. I'm so sorry.
I'm not going to dignify that remark.
From the Gettysburg Museum of History Studios.
You're listening to Addressing Gettysburg.
I swear. Hello, everybody. Welcome to this episode of Addressing Gettysburg. Today, we're talking about something that we like to revisit often on this show because, I mean, when you're talking about war and battles that employ guns and blades, you're going to talk about wounds. That's an important part of a war, right? I mean, that's what it's about. And unfortunately, that's what it's about. And, you know, during the Civil War, we decided, hey, we should try to save as many of these guys as we can. And they took great notes, photographs, diagrams, all these things. And a friend of ours who's been on the show before, Dr. Craig Miller, has a Facebook page now called Civil War Wounds and Surgery.
Medicine.
Surgery. Damn it. See, I was trying to go off the top of my head, and I didn't want to write it down because I'm like, I could remember that. Anyway, medicine, and there's an ampersand in there as well. And we're going to talk about a lot of, not a lot, but I think what you're going to find to be interesting wounds. I hope you do, because I found them to be interesting. So you're going to be really bored if you don't find them interesting like I did. But anyway, Dr. Craig Miller, thank you very much for coming on the show. Welcome.
My pleasure. Thank you. Thanks for having me.
You are a vascular surgeon.
Correct.
And that is a surgeon who operates on blood vessels.
Right.
And so I would imagine that is, you have to have a very intimate knowledge of anatomy when you're dealing with blood vessels, because there's a lot of them.
Certainly helps.
They go all over the place.
They do indeed.
I mean, they don't have a Garmin for navigating that, do they? Yet? Like, no, right? You have to just know.
No, I'll tell you what, something very interesting when I started to get deep into this particular topic of Civil War surgery. If you look at and this dovetails nicely, we hadn't even talked about doing this. If you look at the surgical textbooks that were out in the early 1860s, sort of in anticipation for the conflict that was coming, they have a lot of anatomic diagrams, not so much of dissections as you would for an anatomy class, but of surgical approaches. And there's a whole chapter in one of these books that contains anatomic drawings, depictions of surgical approaches to the blood vessels. And to my utter astonishment, when I first started looking at this, they're essentially identical to what ours are.
Really?
In other words, in the 1850s, when they're putting these together, the surgical approaches to the blood vessels were the same ones that we use now. And the drawings are fantastic. They look like they could have come from a modern textbook. The difference, of course, was that they didn't have reconstructive options. At that point, the exposures of arteries, for example, was specifically to tie them off.
Okay, stop
just
bleeding.
To ligate them. Yeah,
right.
That was it.
Yeah.
But their approach to get down there was very systematic and made perfect sense, avoiding structures, avoiding nerves, avoiding other blood vessels to get to where you needed to go.
Really?
And now we get down there, and of course we do bypasses, or we do enterectomies, or other sorts of things. And a lot of stuff we do from outside the body. But I thought that was a revelation to me that these guys, it's part of the larger process of recognizing that the whole sort of sawbones myth that's out there is
not true.
Garbage.
I'm glad you're doing that, because I think we live in an age now, especially with Civil War history, where people are taking a different approach to, like, they're revisiting a lot of these things that we just kind of took for granted as being one way. The sawbones stereotype, for example. Yeah, I thought that too. And when I thumb through medical books and I see these intricate diagrams, you know, I mean, like, you've got to dissect a body to make those diagrams, you know, and I mean, that's a lot of work. And that's a lot of thought that's going into that. And it's not, sawbones wouldn't do that.
No.
And I'm sure there were sawbones, but for the most part, they seem to be maybe not, certainly not as advanced as we are now in our medical knowledge, but they certainly were trying, and they were advanced for their time.
They didn't have a grasp of physiology the way we do now, and certainly things like molecular biology and all that sort of. They didn't have any way of knowing about that. But gross anatomy, which is anatomy that you see with your eyes, it may or may not be gross in the vernacular sense. Oftentimes it is. Yeah. But they were within a spitting distance of what we know.
Yeah.
I mean, because they could do all of that and had done it when that's what you got. You get pretty good at it, and consequently they did. One of my colleagues, when I was announcing, a year or so ago that I was starting to work in this direction, made a remark like, "Well, isn't that all they did was amputations?" And I, at the time, I wasn't too sure. Now I recognize that no, and even if you just look at amputations, there's a level of complexity there that doesn't really. Hasn't made it through to our understanding at large. I'm going to give you an example because there's one case that we're going to talk about. It's Robeson, the guy from the 2nd Massachusetts, hitting the hip, takes a shot to the hip, and we can go into the actual case later. But so if you look at how at that period they broke down wounds of that nature, let's look at just the thigh wounds.
Okay.
Gunshot wound to the thigh, right? They broke those down, first of all, into 3 different anatomic segments: the middle of the femur, the top part of the femur up by the hip, the bottom part of the femur down by the knee. And they did that because they recognized that a wound to the middle part of the femur is probably not going to involve the major joints, the knee and the hip, whereas ones that are lower down very likely will involve some kind of injury to the knee. So you got to put them in different categories because you want to potentially address them differently. Mm-hmm. So, okay. Gunshot wound to the thigh. Well, there's 3 different areas of the thigh now. So we've already gotten it from 1 wound to 3 different types of wounds. And then you talk about what the treatment might be for that. And there's 3 different types of treatment for a gunshot wound at that time. You got amputation, where you remove the damaged limb, obviously. You've got resection, which is where you remove the damaged segment of the bone only, but leave the rest of the limb intact. Okay. And then the third one is not to operate at all and to treat it what they would call, and we do too, expectantly or conservatively. They would just do dressing changes and sort of supportive care. So we're not going to operate.
What about extraction? Like what if it's just the meaty part of the leg or something and they're able to extract the bullet, or would they leave it?
No, they would try and take that. That's a totally separate issue from what I'm talking about right now.
Gotcha. You're talking about bones.
Let's just talk about bone because soft tissue is going to be a different thing.
Okay.
And parenthetically, the bullets, from their perspective, bullets got to come out. If you can potentially do it, get it out of there because they consider that to be a source of inflammation, which was a different definition of inflammation from what we have now. But I'm getting off of my point. So let's say you got then 3. We're still talking about gunshot wound to the thigh involving the bone. So instead of 1 entity, now you've got 3 different anatomic places in which you can do one of 3 different things, broadly speaking. So now we've got a matrix of 9 different things, right? But the amputation could be either done with the circular method, which we can talk about the difference between a circular method and the flat method. So now the amputation, you've doubled the different possibilities there, right? And now let's look at the temporal relationships of these things, because what they would call primary amputation, and we're just talking about amputations now, but we can also go into resections, definitely not the wound dressings. 3 different time periods. The first is called primary. If you can do it within the first 48 hours, they recognize, especially with amputation, that the outcomes would be better for that. If you couldn't do it or you didn't do it within the first 48 hours, if you did it after 30 days, that was called secondary. And then in between 48 hours and the end of that 30-day period was called intermediate. So now we've got, 18 different possibilities for thigh gunshot wounds. It can be amputation, it can be resection, it can be conservative management. Under amputation, you could do it circular or you could do it with a flap. You could do it primary, secondary, or intermediate. So now you've got all these different things. Primary, secondary, and intermediate time courses also apply to the excision operation. Can you do an excision within the first 48 hours? Do you do an excision within the first? So now we're at a matrix of 30 different possibilities between amputation, resection, and conservative management for just the thigh.
Yeah.
And we're not talking about any. Now move it up to the knee, or move it down to the knee, move it down to the ankle, to the leg, which is what they would call from the knee down, chest. And then you start extrapolating to all the different anatomic areas and recognize that when you're on that battlefield, out at Spangler's farm or whatever, and somebody comes onto the table who's been selected by the triage people that needs an amputation, that doesn't mean that the decision's over. You got a bunch of decisions to make. So the level of complexity is much higher.
And you're exhausted. Going back to the last time you were on with sleep deprivation, right? These surgeons have got to be exhausted. They are exhausted. They're not getting sleep. And you got to make, you got a guy coming on the table with a thigh wound, and now you have 30 options that you can go through. And, but you got 20 more guys writhing and moaning, waiting to be seen. I mean, the pressure on these surgeons.
A lot of time, the fact that you got those other 20 or 200 that also need something done would drive the decision making, because you might look at somebody. Rosen's a good case, actually, where the surgeon looked at it and said, I don't want to amputate this guy at the hip. He's 22 years old, whatever he was, in his early 20s. If I amputate this guy at the hip, his life is just devastated, obviously. Should I do a resection? In that case, he did. But what about the sort of the rank and file when you got hundreds and hundreds of cases? Amputation might take 8 or 10 minutes. The resection operation might take an hour. You don't have that time. It's much more complicated surgical technique than just doing an amputation. So
right,
a lot of times, we just got to amputate because I don't have the time to do a resection on that patient because I got 200 more that need to be done in that primary time period.
Yeah.
And the last thing they're thinking about is sleep.
I mean, I'm not by any means a human anatomy expert, but I have eaten leg of lamb. And so I'm assuming that the femur is surrounded by muscle.
Yeah.
And so if I'm going to do a resection of a section of the femur, I have to cut through that muscle, which is,
substantial.
Yeah. And then I have to cut that section of bone out. Well, I mean, that does sound like it would take a little longer to do. My question with the resection, and we years ago, we had the late Rick Schrader on, and he was an orthopedic surgeon. Yeah, he was the first one. That's where I first learned about resections. And I know I asked this then, and I don't remember the answer, but if I'm missing a chunk of my femur, how am I walking? Or
poorly. You're walking very poorly, and in fact, by the end of the war, even before the end of the war, the conventional wisdom was not to do resections in the lower extremities. But you'll still see pictures of people from after the war that were compiled by the War Department and the medical department of the Army, where you'll see people who did survive that operation, and you'll see many more in the upper extremities, but there are some in the lower where you'll see there's this kind of weird leg hanging there. What's happening?
Is it completely useless? Or does the rest of the bone structure and muscular structure compensate?
It depended on the individual, because in some cases, yes, it was just something they dragged around and it was awful. And they'd even sometimes go back and have it amputated.
Right.
Have taken off.
Just be like, get this off me.
It's just in the way. Yeah.
Oh my God.
But
that's awful.
Sometimes the thing would develop in between the areas of, say you've got some bone here and you've got bone here, but you've taken out the damaged part there. Sometimes the body would fill in with fibrous tissue. It was called pseudoarthrosis, which means false joint. And it would fill in with stuff that would sort of take the place of cartilage, or more. It was more like cartilage that would take the place of the bone and allow you to do a little bit of movement and motion. And that happened in the upper extremities too, where you'll see the pictures. You've seen, I'm sure, a bunch of pictures of guys where there's no shoulder.
Like a deflated balloon.
Yeah, there's no shoulder there.
Yeah.
But yet they could actually do some stuff. It wasn't the same as having a natural arm, of course, but they could do some
small things.
Yeah, because of this phenomenon of pseudoarthrosis that had taken place.
That's fascinating. I didn't know about that. Okay, let's get on to some cases here, unless you didn't finish your point.
No, I did.
Okay.
It's my point with all of that was simply to approach the surgeons of that day with some respect. They not only did they do a job that was overwhelming, and you talked about the sleep deprivation. Many of the surgeons that were here at this battle were knocked out of the service, some permanently after that, because they got sick. There were communicable diseases still. They might get typhoid while they were taking care of these people, but the exhaustion knocked them out. And the numbers are something like 40% of the surgeons here, I'd have to confirm that, but that's just my estimate, were unable to function for weeks after the battle because they had essentially given it all for those first several days and trying to accomplish as many operations as possible to save as many lives.
You said before that the outcomes were better if they amputated within 48 hours. Yeah. Do we know now why that is, or is that just one of those? Okay.
Yeah, absolutely. I mentioned the idea of inflammation before then, which they recognized as this sort of systemic response to the injury, involving shock, fevers, all sorts of things. And then the wound behavior that we now recognize was pathologic, but they accept it as normal, laudable pus and all that sort of thing. So if you have a wound of the nature that we're going to explore here, it's going to set up what we would call an inflammatory reaction too, which is just a systemic response to injury. So they sort of were knocking on the door of what that was all about. And what they realized was that if they could get the amputation performed before that, they would say set in, that the patient would do better. And that was observational. If we get the leg off within the first 48 hours, more people live than if we do it a week later. And when they ultimately broke down the figures, because they collected tons and tons of data, when they ultimately broke that down, it was borne out.
Yeah.
But their experience had already taught them that if you get it within the first 24 to 48 hours, more people will survive that operation.
And when they say inflammation, is that's not their word for infection? Like they knew what infection was, right?
They didn't know what infection was because they didn't know about bacteria.
So they didn't have a word for infection.
No, I think the word was out there, but the word infection was not interpreted the way that we would, which is microorganisms that have gotten into the body and are causing the responses that we recognize. They saw those responses, didn't know what was causing them. It was just
inflammation.
It was inflammation.
Yeah. Okay.
Laudable pus.
All right. Dick Yule, Richard Yule. Tad, you can go to the camera 6 there and people can see. This is from Craig's Facebook page. I'm sure you've already gone and followed it or liked it or whatever the hell the difference is. I don't know. But here's Richard Yule. We all know him. 2nd Corps Army, Northern Virginia here at Gettysburg. Jackson's big successor. And he lost a leg. What was it? Manassas, 2nd Manassas, right?
Yep.
And let's take a look at his wound. Ugh. So this looks so painful.
Yeah, imagine so. Yeah.
Right on the joint, right there on the knee. And it looks like it goes in up at the top. I guess they would have popped the kneecap off, wouldn't it?
It split the kneecap. We have a great description of this. There are a couple of descriptions for this wound. One of them comes from Campbell Brown, who was a military guy. And
wasn't that his son-in-law?
Correct. Yeah.
Yeah. Okay.
But the one that's pretty dramatic. But the one that I think is a little more trustworthy comes from the surgeon, which is Hunter Holmes McGuire. Who I'm sure
we have his picture here. There he is, Hunter McGuire.
Hunter McGuire.
Very stern looking.
You'll probably remember him as being the surgeon who took off Jackson's arm, too.
Yep. Yeah. So Yule inherits him.
Yeah. This is before that, though. This is in August of 1962. So Jackson hadn't been.
Oh, that's right. He's still alive.
Later. Yeah, he's still alive.
Okay.
But McGuire got got a hold of Ewell. And the reason why, if you look at it, it's kind of a strange trajectory of the bullet.
Yeah.
And it goes through the tibia after going into at the level of the patella, the kneecap, and it cracks the patella, then goes in through what we would call the tibial plateau, which is the top of the tibia bone, and then it went down the shaft of the tibia and split it and fragmented it, as is depicted in that drawing. And then the bullet was sticking in the soft tissues when McGuire got him.
Was he? Do we know? Was he sitting on his horse when this happened?
No, and that's what I was going to say. He was squatting underneath a tree.
Okay, I was going to say it looks like he's like kneeling or squatting or something where the bullet's coming right at his upper, like above the knee, right?
Yeah, and it came in at very low. I mean, that must have been just a few inches off of the ground, and the shot came in and got him at a really bad angle.
God, that's got to hurt. That's got to be the worst, the knee.
Yeah, that was pretty bad. I've got the description that, if I can find it here, that McGuire gave of that. He said, this is a quote from Hunter McGuire. It says, he was kneeling on the ground and looking under some pine bushes to get a better view of the field when he was hit upon the left patella, nearly in the center of it, and his leg being flexed, the ball passed downward, striking the head of the tibia and splitting it into several fragments. The bullet finally lodged in the muscles of the calf of the leg. He sent for me at once, but the messenger failed to find me. And I did not know he was hurt until General Jackson sent his aide de camp to tell me. Ewell was still laboring under the severe shock of the injury when I found him. In gunshot wounds of the knee, the shock of injury is severe, but it was especially great in this instance. The general's health, naturally not very good, was unusually bad at this time. He had also lost a great deal of sleep, and the night he was hurt was compelled to drink a large quantity of strong tea to keep awake. He was so much exhausted when he was shot that his surgeons, McGuire means the ones who first examined him, thought at one time he would die from the shock of the injury. When he had sufficiently recovered from this, I advised him to submit to the amputation, but he consented very reluctantly. I amputated the thigh just above the knee, performing the operation as rapidly and with as little loss of blood as I could. Okay, and then you must say, well, you got the leg off, and by the way, the data from the medical surgical history of the war said that a lower thigh amputation of that nature had about a 50% mortality. So 50% survive, 50% would not.
Because the closer you get to the trunk of the body, the more deadly it can be. Is that right? Or is it?
Yeah, no, that's correct. Yeah, the farther out it was, there's an exception. It's either the wrist or the ankle. I can't remember. But the further out the amputation was, then the higher the recovery rate was.
So that makes sense. Then if you get hit in the knee, that's about halfway up to the pelvis, to the trunk of the body.
So you think, well, okay, we got it off. He's going to be okay now. McGuire goes on. About 10 days after the amputation, to escape capture, he was carried on a litter by some soldiers near 50 miles. That makes Dan Sickles' litter thing look.
So wait a second. They're carrying like no cart or anything. Like they're carrying him on a litter.
That was what they did with Sickles.
Not 50 miles.
Not 50 miles, but it was to Westminster. It was 20, 25 miles.
Oh my God. But not on a litter.
It was on a litter, yeah. That was Sickles too.
No. Wait, hold on. Maybe I'm misunderstanding.
A stretcher. He's on a stretcher.
No, I got it. He's on a stretcher. Yeah. Carried by humans that distance, or on a stretcher on a wagon?
Carried by. This is not all that uncommon. That was the case with Sickles. It was the case with Ewell. It was the case with Chamberlain, that we'll get to. They carried Chamberlain to City Point from Petersburg on a litter too. And the thing was that, especially on those fields, if you put them on in an ambulance, which was probably available, it may not have been with the Confederates. I don't know the ins and outs of that story completely, but it was available for Sickles and for Chamberlain. But you're going over rutted roads, and the soldiers called the ambulances avalanches because they were so rough, and going over corduroy roads or rutted roads or something. They talk about dreading the ambulance ride more than anything else, because you're just going to get bam, bam, bam.
Well, right. But when you've got a serious wound like Sickles, like Chamberlain, isn't time of the essence? Not comfort? Or is this after they've been treated?
Yeah. In Chamberlain's case, in all of the cases, they've already had the operation.
Okay.
Yeah.
So they're stable.
Yeah.
This isn't like they just got hit and now I don't walk you 50 miles.
Have fun.
Where would you like to go, General?
The no, what was it with Sickles? He had 40 people, right? And they took him in turns. 4 guys, and then it's your turn, then it's your turn. And that's why there was a whole company of
I can't imagine. That's amazing, though. I can't imagine.
And Sickles, of course, is
smoking a cigar
the whole time. Jesus, fine gentleman you are. So, but that's not what I was going to get at here. He said, okay. He was carried on a litter. The motion on the litter caused the bone to protrude. Oh. So the wound broke down. This is 10 days after the operation. And McGuire, being the surgeon, is going to blame any wound breakdown on somebody or something else. It certainly wasn't him, right?
Well, he recommended amputation.
He did.
Yeah.
You would be dead by then if they hadn't. So after, as a consequence and his bad health, the wound sloughed. After much suffering and the loss of an inch of bone, he got well enough to go about. When one day he was so unlucky as to let his crutches slip from under him, and falling upon an icy pavement, he reopened the wound and knocked off another piece of bone. Oh. So, and this is all in the interim, that brief interim, by the way, between late August when he was wounded and being put in command of the 2nd Corps up here.
So this is post-amputation.
Yeah.
Okay. I'm sorry. I misunderstood you before. So I thought it was before amputation while he's still being reluctant. So this is after he's got the leg chopped off.
Yeah. Gets the leg amputated, and 10 days later, he has to escape capture, has to be carried off. And it doesn't sound like they dropped him, but just the motion of the thing, the bone stuck out. So the wound broke down, the bone stuck out.
Because, so for people who are trying to picture that and why that would happen, like myself, you chop off a leg, you amputate a leg. You've got extra
chop off.
You've got extra skin that you have to close the wound, right?
And muscle, soft tissue. Yeah, you want good coverage. It's important.
Okay, so that is basically acting as padding to the bone, right? And so for that, for the bone to be protruding from that wound, what is going wrong?
Well, a couple of different things. Infection can do that. It can even do that nowadays. Trauma definitely can do it if the wound hasn't healed all the way. If you fall like he did on the icy pavement, or get knocked about by well-meaning stretcher bearers, then it may be enough to just poke through the healing and whatever sutures he used at the time. I suppose it was probably a combination of all that. I'm sure that McGuire was a renowned as a good technical surgeon, so I'm sure that the operation that he did was appropriate, and he covered the bone with good soft tissue like you're supposed to. Not only to optimize the healing, but to allow there to be wearing of a prosthetic later on.
So that was my next question. When you wear the prosthetic later, I mean, I'm guessing it doesn't hurt?
I think in most of the cases back then, it definitely hurt.
Okay.
And even nowadays, there's pain in an amputation site with a prosthetic is not uncommon.
Because even if you've got that padding of the muscle and the flesh between the end of the bone and the prosthetic, putting all your weight on it, like I can't imagine. You know what I mean?
Yes, I do. And you see that all the time in cases of amputation from trauma or cardiovascular disease that patients even today will oftentimes have problems with stump issues. Now, our technology, especially in the last 25 years, but even up until then, is miles ahead of what they had.
Oh, sure.
Then, I mean, just miles ahead. They've got...
those guys are running with those things.
Oh, my God. They're prosthetics. I saw a prosthetic not too long ago. It's Wi-Fi.
What?
Yeah. You
can listen to music through it?
No, the settings on it can be altered from a distance.
Really?
Yes, by the physical therapists and the orthotists, physical medicine and rehab people.
Oh my God!
They can alter the settings on it. Yeah, it's phenomenal.
That's amazing.
Yeah, it really is. Yule didn't have anything like that.
No, he had wood, right? And leather.
And McGuire goes on to talk about that because he says after some months, Yule was well enough to go back to the field again, where he performed some very active service. But from the shape of his stump and an ill-contrived wooden leg he wore, He was frequently troubled with abrasions of the skin, small abscesses, and so on. We talked about that when I was up here before, because there was one story, and I can't remember where I heard it, that he, at the end of the second day, or the end of the first day, somebody had seen him at a well bathing his stump in water there. I don't remember. Was it the Lady Farm? Maybe. Anyway.
Well, that's where his headquarters were, the Lady Farm.
That may have been.
Or no, it was, no. Well, I don't know. I don't remember where it was that he was seen bathing his stump, but it wasn't the Lady Farm. It was that, it's right there at the light.
Hey, buddy. What's got you so down?
Hey, Court. I'm looking for a gift, but I just don't know what to get my Gettys nerd friends and family.
It sounds like we need to have a talk. Come on. You love this place, don't you?
You bet I do. It's my favorite place in the world.
Well, you see, at Addressing Gettysburg, it's our mission to keep these stories alive.
How do we do that?
I'm glad you asked, sport. You see, Gettysburg is the gateway to the most brutal and crucial time in American history, so we interview experts, and our listeners learn with us.
That sounds amazing.
It is! Mike, are you f***ing serious?
What? It's for the commercial. What benefits do patrons get?
You mean besides up to 4 premium episodes per month and Matt being the bee's knees as host? How about early access to special episodes, behind-the-scenes insights, and discounts for ticketed events?
Whoa! None of the other history channels I follow do that for their listeners.
That's because Addressing Gettysburg doesn't take its listeners for granted and really cares about us learning American history.
You know, I should gift my Gettys nerd friends and family an Addressing Gettysburg Patreon membership.
You see, the answer was right under your nose the entire time.
Make Addressing Gettysburg's Patreon a gift for the Gettys nerd in your family this holiday season. Addressing Gettysburg wants you to learn about the Civil War with us, and we need your support. We'll run this ad until it gets annoying, and then we'll run it until you become a patron at patreon.com/addressinggettysburg or by scanning the QR code on your screen. Happy holidays.
The hell are we staring at?
No idea.
There's a marker. There's a marker right at
where the core marker is?
Yeah.
Yeah. Up by
But his headquarters cannon, is there.
Yeah. The core headquarters.
Yeah. So anyway, go ahead.
So in 1866, when McGuire was writing this, he said, now he uses a suitable artificial limb and with the assistance of a cane, gets along right well. He no longer liable to affectations of the stump. So that was the thoughts of Hunter McGuire, who's a really interesting guy, by the way.
Yeah, he is.
Here's a mystery for your viewers or listeners. What was McGuire up to at Gettysburg? He was here. There's almost nothing. I have been able to find almost nothing.
Yeah, that's a good point. You never really hear him mentioned.
I just went through yesterday at the museum library all the files that Gregory Coco used to put together his fantastic books. There's a whole file of Confederate surgeons, maybe 15 or 20 in there that he had memoirs, diary entries from, original documents and copies. And McGuire isn't in there. It doesn't even have a folder.
Yeah, it's funny because when I think of Hunter McGuire, I used to think that he was gone by the time of Gettysburg. That he went away with Jackson's corpse and never came back or something.
The shame.
You know how like sometimes like a person dies and their dog lays on their grave, and I thought it was something like that. And then when I read that he was here, I'm like, well, why don't we ever hear anything about Hunter McGuire here? So good point. We don't.
I mean, we know he was here. Henry Kidd Douglas, who knew him well, of course, said that he checked on him. So, and he wouldn't have missed that who that was.
Right.
So it's an interesting conundrum there.
Well, now that you bring up Gettysburg, why don't we talk about Private Jonathan Colgrove, Company F, 57th Pennsylvania. Here's a picture of him. Here, he's a young man. Looks very young. How old is he?
Oh, 19 maybe?
I was going to say, looks like a 19-year-old. Jeez. All right. And let's take a look at the wound he received. Good Lord.
Right.
Good Lord. And he has some kind of a Bane device here. What is that?
Those would be the cartilages, the cartilages of the neck.
Oh, is that what we call the Adam's apple?
Yes, indeed.
Okay.
Cricoid cartilage right there.
Easy for you to say. All right. So the bullet looks like comes in the base of the skull, kind of.
It's coming in through,
but on the side.
The two dimensions of the drawing are a little difficult. Yeah, a little difficult. The entry point was in the submaxillary triangle, which is
that's what I was
this right
say.
here.
Yeah,
it's right here, and so it's coming in there, and then it goes downwards and a little bit posterior, and it injured that cricoid cartilage, which is the Adam's apple that you saw in that picture, and also injured his esophagus. So it got the airway and the digestive tract there, or otherwise we wouldn't be talking about him. It did not hit the jugular vein or the carotid artery.
Right. Lucky.
Because if it had, we wouldn't be talking about him because he would have been KIA.
Yes.
But he survived that wound. For the first few days afterwards, they put him on a regular diet, just full diet, and the fluids came out through the hole.
Sure it did.
Yeah, along with air, just as you might expect it would. But he was a very, very lucky guy because all of it spontaneously closed up with no treatment.
Really?
Yeah, no treatment other than dressings.
Didn't sew it up or anything?
Nope. They left it be, and it spontaneously closed. Excuse me. I think within 2 weeks or so, the only thing that was left that wasn't completely normal on him, other than what the appearance would have been, physiologically speaking, was his voice. He had what they called partial aphonia, which is a complex way of saying that he had a hoarse whisper.
Right.
Yeah.
He was a horse whisperer.
And somebody online asked, did that ever get better? And I don't know the answer to that, but I did see his obituary from many years later, and there was no mention of that. There was mention that he was a popular figure in town. They closed down the town for his funeral. So he was in the town of Colgrove, too. Interesting.
Yeah. Yeah. Go ahead. Sorry.
Very, very lucky guy to have had a neck wound of that nature and missed the major vessels.
Now this is interesting. Now you have some shorts on your channel and everything, and I don't think this is going to get me any kind of copyright strike or anything like that. So we'll try. But I'm going to play one of them now, and that'll give us the story of this guy, because this guy is crazy. All right, let's
even better with that.
Let's try to get some sound on it here. Come on, Tad. There it is.
Yes, that's my fault.
What a stupid thing that is. Okay, here we go.
Corporal William Mix was struck in the chest by a cannonball and survived. At Gettysburg, on the afternoon of July the 2nd, 1863, Mix and his 2nd New Hampshire Regiment were ordered to support Union artillery along the Emmitsburg Road in the Peach Orchard. During the furious artillery duel that preceded Longstreet's assault, Mix was hit in the chest by a 12-pound solid shot. He was carried to a field hospital, coughing blood. With no wound to treat, surgeons prescribed volatile liniments only. Incredibly, Mix survived the injury, crediting a book in his pocket with helping deflect what must have been a glancing blow from a spent shot. Mix later became an officer in the 19th U.S. Colored Troops.
What is volatile liniments?
Bengay, basically.
Okay, so like a ointment?
It was an ointment that you would put on that would give you a feeling of, I forget what was in it. Might have been turpentine or something like that. I have to look.
Sounds volatile.
Yeah,
The most feared complications.
Oh my God! Sorry.
Volatile meaning that it would sort of evaporate, and then it would give you that feeling that at temperature. It's just like Bengay.
Not explode.
Yeah.
or catch on fire. So he gets hit in the chest, and yeah. So it mentions that it's a spent shot. By the way, that voice, great impression of that announcer that you did there, because he narrates a couple of documentaries I've seen about Albert Fish. You know who that is? He was like a serial killer in like the early 1900s, and the other one is what's that doctor in Chicago that was killing people during the World's Fair? He had that. So
H.H. Holmes.
H.H. Holmes. Yeah. Did a couple of good ones on that. That guy's got a great voice.
We spare no expense.
Yeah.
Like Jurassic Park.
All right. So he gets hit. No visible. He had a bruise, right? But there's no like open wound. Coughing up blood, I'm assuming, right? It must have very sore ribs. Right? Like, I mean, it's gotta hurt.
Yeah, I mean the spent that's not in the record. That's just my assumption that there's no way that he was hit by a shot that was coming straight
full velocity.
It must have been a glancing blow, and it must have been maybe one that had already bounced on the turf a few times. Because you'll hear about the stories where people put their foot out to try and stop the ball. Say, I can stop that. That should
be kick it like a soccer ball, and their leg goes flying.
Their leg goes flying instead. Yeah.
Just because you could see it doesn't mean it can't hurt you. You could see cars, but you don't want to jump in front of them.
Yes, exactly. Yeah. So I imagine it was that. He had a blanket across his chest, too, that I didn't mention in there, but blanket and the book, and he said that was why. But yeah, he wasn't okay. I mean, he was coughing up blood and mucopurulent stuff, as they call it, which is purulent as pus.
Like pus, yeah.
So, and muco is self-explanatory. So, yeah, I imagine he probably wasn't all that pleasant to be around for a while that was going on. But ultimately, he survived to tell the tale. Very unusual.
How long did he live?
I don't know. I have to look that up. I don't remember that I had information on what became of him afterwards. Some of these people drop out.
Yeah.
After their service record is gone, they're hard to find unless you really track them down on Find a Grave or something.
Who's got the time for that? Doing a Facebook page, right? Yeah. It's not. It's not your real job.
Yeah, this is the story. It's right there. He's in the medical and surgical history, which is where I found him as an example of an internal wound without external. And that, when I first read it, I thought I was pretty skeptical. This isn't. And then we talked about the reasons why it might have been true. But you've got to give credit to the surgeons who compiled that medical and surgical history, because if they didn't believe something, they'll say it right there.
Yeah.
They'll say, this is, I'm thinking specifically of gunshot wound to the stomach, to the organ, the stomach, and how there were no survivors that were documented. And then they present a case that happened here, actually, it was a Confederate, where he was an apparent gunshot wound to the stomach that survived. And right there in the collection, in the book, they say, we don't really buy this one. Yeah, but we're reporting it.
How about today? Is it easier to survive a gunshot wound to the stomach than the organ in the stomach?
Then, or
yeah.
I mean that entails an operation for sure.
It must burn.
I don't know. I haven't been shot in the stomach.
Well, I would imagine like all the acid leaking out.
That's a problem.
It's got to burn.
Yeah, because that'll, even if there's no infection, that'll set up peritonitis. Which is a great killer then, of course. A terrible way to go.
And that is what again?
Peritonitis is inflammation of the lining of the abdomen.
That's right. Yeah.
And even if it's not infectious, the acid from the stomach will set up a chemical peritonitis, which you can also have. That's what happens with perforated gastric ulcers too, which is they'll kill you from peritonitis.
Leaks out. I know somebody who's, I think it was his nephew, was on a trans-Pacific flight. And
perforated ulcer,
and he was kept getting sick. They had nowhere to go. They couldn't, and ended up being that his stomach had somehow torn and was leaking. And it was horrible. So I guess that's what that is.
I can't imagine a worse place for that.
That's again another reason why I don't like to fly. You never know. Well, believe me, when tragedy is going to medical tragedy strikes me, it's going to be over the Pacific. That's just my luck. Yeah.
I'm going to be on a Trans-Pacific flight next month. Though. I'm going to be thinking the whole time about it.
Well, so speaking of other ways the body can work against you. Here's something we've all heard of. I'm going to play your short here. Let's see who's narrating this one. All right, let's once again. God bless America. All right, it's not. Why is it not? Oh, because I muted the laptop thing. Let's try this one more time, ladies and gentlemen. Take two.
The most feared
What?
We'll fix this in the mix.
Yeah, right. Now I got to do it again. Okay, here we go.
The most feared complication of Civil War surgery was hospital gangrene, a rapidly destructive infection of wounds, notorious for spreading in crowded hospitals and turning a survivable injury, or even a clean amputation stump, into a life-threatening catastrophe. Its appearance on a hospital ward was terrifying. Perhaps the closest modern clinical entities to hospital gangrene are necrotizing soft tissue infections, sometimes referred to in media reports as flesh-eating diseases. In the era before antibiotics, Civil War surgeons treated hospital gangrene with isolation, ventilated wards, and caustics like bromine. When necessary, they resorted to radical excision. The mortality of all types of gangrene in the Civil War was a ghastly 45%.
So I was, I'm doing some guest spots on another podcast, and we're analyzing North and South. And I was watching an episode last night, and one of the nurses says, tell the doctor that his infection needs to be cut out before it spreads. Now, my nurse would tell a surgeon that, whatever. But I always wondered that, like, you're cutting out the infected tissue, I'm assuming, not like, how do you cut out the infection? How does that work?
Yeah, you got to tell the doctor. Reminds me of those pharmaceutical ads where it says,
"Oh, tell
your doctor if you have severe hepatic disorders."
Right?
Shouldn't your doctor tell you?
Right, that's his job. Yeah,
yeah. Well, in the instance of let's talk about hospital gangrene, okay? And then I'll answer that question.
Go ahead.
Part of that. It needs to be distinguished from sort of garden variety gangrene. When we think about gangrene now, and they were aware of this, the same thing that I'm about to talk about then too. We think about death of tissue usually from vascular insufficiency, arterial insufficiency.
So it's not getting enough blood.
Not getting enough blood, not getting enough oxygen, and the tissue will die. We see this, of course, my line of work is a vascular surgeon all the time, in atherosclerotic disease, particularly in folks with diabetes who have the blockages developed from atherosclerotic plaques in the smaller vessels that we can't do much with surgically. And those are usually the ones who come to amputation from gangrene. Now, we're going to get to, I think, to private January. That's gangrene, not hospital gangrene.
Okay.
That's garden variety gangrene. It can become infected, but generally speaking, it's just sort of a black shriveling of tissues. Almost looks like what would happen with a cadaver.
So is gangrene itself not an infection? It can cause infection.
Gangrene is necrosis of tissue. It's death of tissue.
I see.
Dry gangrene is death of tissue that mummifies. So it just becomes shriveled and
like
black.
Frostbite?
And frostbite's a good example of that. But if that becomes secondarily infected by bacteria, that can become wet gangrene where it smells terrible. It's
south of cheese, as they say in Private Ryan.
Yes, nasty fromage. Limburger. And that is wet gangrene, but it's still not hospital gangrene. Hospital gangrene is a bit of a mystery. We don't really know what exactly was going on there. There was a famous surgeon called William Williams Keene.
Great name.
Yeah, his parents must have
hated him.
Yeah, really.
Yeah.
And W.W. Keene was a young man in his 20s, a surgeon during the war, and then became an important figure in American, like a lot of them did, in American surgery throughout the rest of that century. And in about 1913 or 14, he gave a speech where he was comparing military surgery in that era versus what he had done 50 years before.
Okay.
And he has a paragraph about hospital gangrene where he mentions how terrible it was and how lucky you are that you'll never have to see that, because he hadn't ever seen it again after the war. In 50 years of being a surgeon, he never saw it again. So the question is exactly what was going on, and we get a sense of it based on the descriptions, which were very good. It was rapidly progressive infection that they described someone having a normal amputation site. In the morning, a small black slough appearing, and by the end of the day, they're dead.
Really?
Yes. And they were perfectly
What is a
fine.
slough?
Slough is tissue that is trying to peel away. It's dead, and it's trying to peel away.
Yeah.
It's slough. Okay. Yeah, it's trying to peel away. So what you would see then would be this. Well, we saw the picture of the soldier with the arm, the drawing.
This guy?
Yeah, that guy. There's what it looks like, and then the other picture is the same. Same disease entity, a little bit different appearance. So if you saw that in a wound, you know there's trouble. Bad smell, rapidly progressing. The patient gets extremely ill.
Is this what they would have also called blood poisoning?
No, that's septicemia is what they would call it.
Okay.
They would call that pyemia, which just means pus in the blood. We call that sepsis now, or septicemia. And that is what would kill the patient from this. That bacteria that is, we don't know what it was. We can guess and make some educated guesses. But it's really chewing up the soft tissues, moving very, very quickly, and it will eventually get into the bloodstream. And then,
so in this guy's case here, it looks like, he got that cut off above the elbow, and it's getting all gangrenous and everything like that. Would they be able to go and cut it off at the healthy tissue, and that would have saved him, or is he just basically dead? That
guy probably didn't survive. The treatment that they would do at that point in time would depend on who you were talking to. But by about late 1863, one of the things that was working, certainly not 100%, but was bromine. Before that, they would also try nitric acid. They'd put it right on the wound, terribly painful, as you can guess. And then they'd put it sort of like a demarcation line above, a line in the sand above it with the bromine there. And the hope was that it would stop the infection as it got to that point, almost like what they do with fires. You burn
like a controlled
fire
burn.
break, and that was
fire break,
that was the idea behind it. And it sometimes worked. The bromine was actually reasonably effective. They didn't know what was going on, but the bromine is like iodine. It's going to function like that. It's going to be an antiseptic.
Didn't they also use that for indigestion, bromine?
You mean like Pepto-Bismol and indigestion? Yeah. I don't know.
There's a movie that HBO put out called Conspiracy in the early 2000s. Kenneth Branagh is in it, Stanley Tucci, a bunch of other people. And it's about the meeting at Wannsee that the Nazis had.
And Heydrich.
Heydrich, yeah. And there's a scene where no, bromide. Never mind.
Bromide.
Yeah, not bromine. Sorry.
Close.
I'm just gonna stop it right there because he has indigestion. He's like, I need a bromide.
Oh, bromide tablet.
Yeah. Sorry.
No, it's okay.
Sorry. So very sorry.
No, when I was, I don't treat things of this nature anymore, thank goodness. But I remember being a general surgery resident. And I was at Ohio State, and we would get during the summer, we would get these referrals that would come up from the Ohio River, the towns on the Ohio River, like Marietta, Gallipolis. Don't ever swim in the Ohio River.
Doesn't sound appealing.
Because it would happen, I suppose, once a weekend. Somebody would be swimming in the river, step on something.
Oh, yeah.
And by the end of the day, they'd been helicoptered up to us, and we were doing above the knee amputation.
Really? Oh, my God. Really?
Yep. And what I'm talking about there is what we think is probably the closest analog in modern times to what hospital gangrene was. And I alluded to it in that video, which is sometimes your flesh-eating bacteria or these necrotizing soft tissue infections, like necrotizing fasciitis.
Yeah.
And I have seen with my own eyes where we draped a leg out to do an amputation at the knee or maybe slightly above it. Went out to scrub my hands, and you can see the mark. It's discolored where the bacteria has gotten to. Going out to scrub the hands, coming in 5 minutes later, and it's an inch higher than it was.
Really?
Yeah, when I was in there setting the patient up. It moves that fast. And that's probably the closest thing. Those are caused by infections that are with bacteria known as Clostridia, and then there are multiple mixed organisms that sometimes will get together and have a party.
Oh, God. So you're just going swimming in the river and you dive in and your foot gets caught on some ragged piece of metal or something or cut on it.
Something bad's living in
and
probably
it gets
all the stuff to get dumped in it from
God.
Pittsburgh.
Never. So, any river.
Yeah.
I don't care if it's a place that human beings haven't been to in 1,000 years. I'm not going near that river. You out of your mind? I had a parasite once. It was the worst. And one of the things they asked me was, did you go swimming in any rivers or lakes?
Have you been in the river Nile?
Yeah. And I go, it's December. And they're like, well, did you go to the tropics or something? I'm like, no. What? No, I didn't. I would love to, but I didn't. And it came probably from a restaurant with like people handling the lemons, because I always get lemon in my water. Because the only thing I could think of, because all the other things they asked me, I'm like, no. So it had to be that. So anyway.
And the name of this restaurant is...
Well, that's the thing is, at that time, I went out to restaurants every day. So like, I couldn't even pinpoint it. I would have shut down the whole town if I named anybody. So I was just like, I don't know where it came. I didn't want to do that. But it's awful. And from that moment on, I was like, I don't think I want to go swimming in lakes. And it wasn't even from swimming, because I didn't do it. But I definitely was turned off to that idea because it's terrible. I lost 20 pounds, which was nice. Well, because it took me 7 days to go to a doctor, like a typical male, and then it took another 5 days for them to pinpoint what it was. And so I was down like 20 pounds and I said to my doctor, can I hold on to it a little longer until I hit 40 pounds? And she's like, you don't want to do that. You're going to lose muscle too. And I go, what muscle? I said, I haven't shoveled a driveway in years.
The callback, ladies and gentlemen, the callback.
That's a callback through conversation before the show started. Anyway, my point is that, yes, don't go swimming in lakes and rivers. So, what would you do for gangrene today? I'm assuming antibiotic or no, because it's not.
Yeah.
Okay, wait. Before you answer that, let's go back. You keep making a distinction between gangrene and hospital gangrene. And you're saying we're not really sure what hospital gangrene was?
Probably was a necrotizing infection like what we've seen.
Like the flesh eating.
Yeah.
Right. So regular gangrene. So that's just what they called it because it resembled gangrene. Yeah. Visually, obviously, they're not looking at microscopes and
correct, but they had them, but very few of them were actually
thinking to use it.
And what it looked like was to them was a really terrifying, extremely rapid progression of gangrene. Now they had seen, they knew about vascular gangrene from ischemia too, lack of blood flow. They knew about that. This was just an example of something that looks just like that, but it smells really bad. It advances really fast, and even worse, it's super contagious because that's why it would,
did it again.
That's why it would strike fear into the people on the ward because everybody else has got to get in. So it'd isolate them.
That's my next question, though, is the contagiousness. So I'm guessing it's because a nurse is working on a guy with gangrene, and then she goes and doesn't wash her hands and works on a guy with another wound and touches the wound and it gets in the wound. Is that
probably? Yeah, that's probably. I mean, it's there's a certain amount of speculation, of course.
Yeah,
but that would be it, as opposed to being blown by the wind or something, which is something that they were worried about.
Yeah, God, those places had to be hell on earth. Those hospitals, they had to be hell on earth. The smells, the sounds, and then the fear of infection spreading, and you don't know what the hell it is.
And it happened, I mean, a good read, by the way, is Louisa May Alcott wrote. She was a nurse for a while in a Washington hospital. She was living up in Boston, decided that was the way she wanted to contribute. And she wrote under a pseudonym, she wrote her experiences. And she's a really good writer.
Yeah.
It's very, very entertaining. But she got sick. She got typhoid and never really recovered from it either. She had that the rest of her life, the after effects from it. And she was only in those Washington hospitals for a few weeks.
All right. Private John January.
Yeah.
Now, everybody knows the story here at Gettysburg of
Wilkeson.
Thank you.
I figured you were going there.
Forgot his name. You know, there's even some. I know Tim Smith questions whether or not he actually did amputate his own leg.
Yeah, that I don't think I went looking for that at some point in the last few months, and there is no primary source documentation. That seems to have evolved out later on.
Yeah,
maybe
isn't that amazing?
Maybe by the private tour guides and things that were out here.
Yeah,
that came out. Now I'm sure his leg was mangled badly, and he may have looked at it and said but I don't. There's no witnesses to that. No primary source witnesses.
Well, this guy, John January, great name, from Illinois. Yeah, he does something here. And where does he do it? Does he do it here?
No, he was. This is in 1864. He was captured. He was cavalry, and he was captured and sent to Andersonville, which everybody loved. He lost a bunch of weight. Was sick. Everybody was, but he was had been transferred to Florence, South Carolina, and he was at the stockade there. And he said that he was down to 45 pounds weight after weighing 130 at the start.
How is he not dead?
Yeah, well, he said when they got him back into I forget whether he was liberated, at the end of the war, or whether he would have been exchanged.
Is that information in your video about him?
That information isn't, but he was down to 45 pounds, and he said that the Union doctors, when they saw him, said, "You're not going to survive." So
45 pounds.
He was
my dog is 70.
I got you beat. Mine's 170.
God, really?
But anyway, we got a Mastiff.
Oh, okay. Yeah, those are huge. A friend of mine had 2 of those. They're nice dogs, though.
Yeah,
you could ride them, but they're nice dogs.
So January was supposedly down to 45 pounds, and his condition was so bad that he developed gangrene, old style gangrene, ischemic gangrene. So it wasn't hospital, but his feet had turned black, and he couldn't move them or anything, couldn't feel anything anymore. So he, according to his story, told the stockade surgeon, "Can you take my feet off? They'll kill me. I know that inflammation will get him," which may or may not have been true. But the surgeon said, "You're going to die anyway. I'm not going to operate. You might as well." What was the quote? Is "You might as well die with 2 feet, buried with 2 feet." It was something. It was good. Meet your maker with 2 feet. Something. Right. It was poetic. And January said, "I want to live," and he supposedly borrowed a pocket knife and cut off his own feet. The reason why I say supposedly is there were 2 prisoners who, after the war, said that wasn't true, that January didn't do it himself, that it was actually done by others. But there was 2 separate people whose stories don't jibe with each other either. Yeah. So you can't tell whether he was telling the truth and these guys were just trying to undercut him, or because January had some gigantic pension. He had like the biggest pension I've ever seen. I think he had $100 a month pension. Wow. Yeah. Chamberlain had $30 a month.
Wow.
At Digital History Pioneers Foundation, we are about grassroots history on digital platforms. That means we are about podcasters, documentarians, YouTubers, and even TikTokers. All of these creators are out there trying to share their love of history with the public. They don't need ideas, they need funding, both from viewers and corporate donors. DH Pioneers' initial funding focus is on the Civil War era, with a special emphasis on the Addressing Gettysburg podcast. So be a vital part of the unique content Addressing Gettysburg has in store by donating at dhpioneers.com and help bring your love of history to the people. Digital History Pioneers is an IRS Section 501c3 approved charitable corporation that makes any donation tax deductible to the fullest extent of the law.
But he had $100 a month, and the idea was that maybe he had embellished his story somewhat in order to get that pension. But
so maybe people were just jealous that he was getting a big pension.
Maybe so, yeah. But as I say, the 2 individuals who were both actually they were there at Florence, and they both did work as nurses, but they didn't mention neither mentioned the other one, and their stories don't add up together. So we don't really know. But January said he was always consistent, and he never addressed the doubters either.
So, but amputating your own feet with a pocket knife. Again, now Bayard Wilkeson, pocket knife.
Yeah.
Okay. So it seems like there is a theme of people with pocket knives cutting off. I could certainly cut my skin with a pocket knife. When I get to that bone.
Right.
So what's going on with how's he doing that? Is he just shaving the flesh off of his feet and then saying, somebody cut the bone, please?
In that video.
Well, let's watch the video here. Here we go.
Amputation was the most common and dreaded operation of the Civil War. One man claimed to have amputated both of his feet himself. John Wales January was a trooper in the 14th Illinois Cavalry, captured in 1864. In a prisoner of war camp, he grew sick and malnourished. His feet became gangrenous. Knowing he would die otherwise, January begged a surgeon to amputate.
Right there. Can you pause that?
When the doctor refused.
Now, look at the end of the amputation. So he didn't amputate through the bone. He did what we would call a disarticulation.
Disarticulation. I was going to say that. Okay, so he removed the feet bones from the ankle joint. Is that
just
right?
Cutting through the soft tissue, yeah.
Yeah, so he's basically like when you rip a leg off of a chicken.
Jesus.
I'm not going to...
Oh, excuse me. I'm so sorry.
I'm not going to dignify
Not a live chicken. I'm talking, I got a nice roast chicken there that I got at the supermarket because I'm too lazy to make dinner on the way home.
And we're seeing how he got this parasite. Right. Look what he does with his food.
I just rip live chickens apart and eat them. I don't bother cooking them. And you're taking off a leg. You want a drumstick. And then there's no, you got to struggle with it. You get a knife, you stick it in there at the joint, right? And you disarticulate it.
All these years, that's literally never occurred to me, but yes.
Thank you.
Actually correct.
Thank you.
Yes.
Honestly, be honest with me. Do you think I should have been a doctor? Thank you.
It's not too late.
I thought so. It's definitely too late.
Matt, I got a pocket knife right here for you.
I can disarticulate your foot.
See?
Yep.
There you go.
I know how to do it. Listen, if we're ever out in the woods for whatever freaking reason and you get hurt, Tad, make sure there's a pocket knife.
Yeah. Maybe you get caught in a bear trap, then you could actually use that.
Poor Tad.
Okay.
So now looking at the picture there, we see that. So it's
the bone's sticking out because he just cut the foot off by cutting the tendons and the ligaments.
Now, would that not have been too painful for him since it was basically a dead limb?
No, probably didn't feel a thing.
Right. Okay. No. Just like how guys would like cut their toes off if they had frostbite because it's dead.
It's dead, including the nerves.
Right, yeah. It's all just black and dead and gross.
Yeah.
Amazing. Let's watch the rest of the video, though.
He borrowed a pocket knife and did it himself. January survived and lived another 42 years. The man who saved his own life by the most extreme of measures.
The most extreme of mustaches, too.
Amputation.
That's a great mustache. That is, it's amazing the how AI makes all this stuff so much easier.
AI.
Yeah.
That's not the only AI in there is my voice being duplicated by that. Everything else is.
No, I know, but I'm saying like the AI just because if you're to do that the old-fashioned way,
it'd take forever.
You've got, and then you're gonna stumble over words. You got to go back and do it again. AI gets it, boom, and it sounds like that guy from those serial killer documentaries.
Oh, it's not that easy because AI doesn't pronounce things right.
Yeah, that's true.
It doesn't pause when you want it to.
I know.
You got to put all those things into there.
I know.
And if you actually spell somebody's name right or pronounce it wrong, so you got to spell it phonetically.
Well, that's how I always know when I see that's one of the ways I could tell when I see a Gettysburg history video on YouTube and they pronounced Harry Heth. And I know the person just Wikipedia'd Gettysburg, right? And copied it all into the thing and just told AI to read it, and AI doesn't know. And this person doesn't know any better to spell it phonetically so that it says it the right way. Yeah, I know what you mean.
So when I do fair, I used to do more cross country, like long distance driving, right? And so I got into listening to books. And now, of course, you can do it. You can just stream them and all these things. And every time I listen to a Gettysburg one that had anything to do with, I'm just waiting. I'm going, it's the first day. What's he going to say?
Yep.
And it's Harry Heth. And it's,
the Stephen Sears one does that, and it drives me nuts.
It does.
Yeah.
Yeah,
because he says it a lot.
I was just listening to, there's one called Surgeon in Blue or something. It's about Letterman, Jonathan Letterman. And it's the same deal. It said Heth, and I can't even, after that, I just turned it off.
That tells you that the author didn't even have anything to do with the recording.
Right, because he would have corrected.
Yes.
He would have said no.
Like he wasn't even in this recording session. Like they couldn't even FaceTime him in, It's just like, no, we got it. And
Burns is like that too. He I don't remember where they said
George
Harry,
Burns?
Gracie. Ken Burns.
Oh, Ken Burns.
When he's talking about, the Tarrytown Road and
well, so the Tarrytown Road, I wonder if that was written that way or if it was a transcription because they went from handwriting and it looked like N's or R's, like it was misspelled with two N's, but they look like R's, and then they transcribed it into, typewriter as Tarrytown.
Yeah.
I always wonder that. I should. Yeah. Tarrytown, Darius Cooch. It sounds so dirty, Watch your mouth, Ken Burns. Yeah. But but again, the amount of work that went into doing that, you can forgive these little mistakes. You know what I mean?
And by the way, the zooms that you do there, those are called Ken Burns zooms.
Yes.
That's named after him.
Yeah. No, he created a whole new way of doing things. Okay. So this one isn't on our list, but everybody has seen this picture. And I think a lot of times I see it on social media and they depict it as like a guy who thinks he's cool, kind of like, it kind of reminds me of Ethan Hawke as John Brown.
Oh, his coat.
But this guy, Francis Jefferson Coates, shot through the eyes.
Mm-hmm.
Shot through the eyes. Okay. And here he is. Let's watch this. Oh, God.
And Coates was shot through both eyes at Gettysburg and survived. The 19-year-old Coates was a member of the Army of the Potomac's famous Iron Brigade. During the furious combat on July 1st, 1863, he was hit from the side by a round that destroyed both his eyes. He was then bayoneted and left for dead. He was found alive days later and treated first at the Battlefield Seminary Hospital and then in Philadelphia with dressing changes and removal of bone fragments.
Ugh.
Coates went on to marry and father 5 children. He learned Braille and worked as a mechanic and broom maker. He won the Medal of Honor for his courage at Gettysburg. His regiment's monument still stands near where Francis Jefferson Coates was wounded on that long-ago summer day.
It's the eye wounds because what's his name? Paul, General Paul, also.
Yeah, Gabriel Paul.
Yeah, got shot through the eyes, and I don't know if I could live without my eyes. I don't know if I'd want to. Like once you have that, and then to lose it, it's got to be tough. And he went on to be a mechanic and a broom maker, and have 5 kids. Which you don't need eyes for that. Well, I guess you do if you're visually stimulated, but still, the point I'm trying to make is,
you can edit that out.
Nope.
My kids are going to be watching this.
Well, how old are they? They might not understand what I'm saying. So the point I'm trying to make though is like that is it has to be psychologically losing your eyes and your vision, like got to be tough to do. And then go about your life and actually have a productive life afterwards. Like I always admire people like that because I know me, and I would not be able to do it. There's certain things there's certain adversities I just know I can't overcome. I won't even try. People are like, come on, Matt, you got to try. Nope, just not doing it. Not worth it for me to go out there in public.
Especially here. What's with the stoplights here? Sorry, I digress.
It's just too many.
Yeah, too long.
They're terrible. Yeah. Too long. The yellow's too short. The green is too short. Mm-hmm. The reds are very long. Yeah. I don't understand. Anyway, we were talking.
The psychology of that must be overwhelming. I think it was a different era in the sense that you're just, it was expected that you would make the most that you could of what was left.
Yeah.
And he certainly did. He got land too, I think, out in Nebraska. That was given to him. I got a point out that he didn't win the Medal of Honor. He was awarded the Medal of Honor.
Yes.
Yeah.
Be careful.
And so that's a mistake. But yeah, there were several people. There was another guy out on the first day's field who got a very similar injury, a New Yorker. Just got hit from the side and took out the eye, took out this ethmoid area here. Coates couldn't smell anymore either. He couldn't smell.
I was going to say, like, what are we going through? So
that's it right there.
Yeah. So it's like he's getting hit temple-ish area, and it's just ripping out everything, and it has to be going through the nose, right, and then out the other side, just all gone, just blown away. You know, he kept fighting. Yeah. You see, that's what I'm talking about. I am like nothing like these people. You're kidding me.
No, that was one of the things that the other people in his regiment is.
Did he just skip the order aim?
He was flag bearer.
Oh, okay.
Yeah. So
that's it. You just stand
there. Yeah. But
God. Okay. So he's the flag bearer, and he got no other wounds after that one.
He got bayoneted because he was laying on the ground.
Because he couldn't see the guy coming.
Yeah. Well, I always assume, I don't know, but that he was laying on the ground at some point. It just kind of said, wait a minute. Okay, I can't really do much anymore. I'm just going to lay here. And somebody came over and jabbed him. But
I never like seeing that in movies when the guy's already down and they bayonet him.
Yeah, like, especially that guy, you get what's left of him. You go, he's not a
he's
threat
not even
anymore.
Seeing you coming.
Yeah, he's no longer a threat. But now they weren't all, they weren't all mean, because one of the Confederate officers took Coates and put him under the shade of a tree so that he wouldn't be out in the sunshine and marginal protection from the elements. But he was out there until the Federal Army took over that which was July 4th. When they moved through there.
Really?
So he, between the 1st and the 4th, he was out there. Yeah.
Oh, what torture that is.
Yeah. He did have some food. In fact, I think he gave some of the food. So one of the watchers can tell. He gave some of his food to the officer who moved him.
Probably thought he wasn't going to survive. Like, what do I need this for? Good God. Let me just a couple of reminders. There's for those of you who have not visited Gettysburg or are about to visit Gettysburg for the first time, I say this a lot, but really make sure you go to the Seminary Ridge Museum and Education Center. It's in the old seminary building, iconic. You get to go up to the cupola, but one of the floors is completely dedicated to when that building was a hospital. And I feel like they have a picture of Coates in there, if I'm not mistaken. Yeah,
I think so.
And but this wound always, ever since I first read about it, I don't know why it never just entered my imagination that this could happen, but I was young. The first time I read about a guy describing seeing a man whose jaw was shot away. They have a picture of a man whose jaw was shot away. It is the most horrifying thing. He survived. And that's not, people survive that wound and they're missing their jaw.
There's a painting
I think I'm more vain than I like to say I am, because all these things, I couldn't go out because of the eyes, the jaw, I just don't want to be seen. That's really what it is. Yeah. I don't want to be seen that way. And that's why I would just off myself. Like I would just jump off of something or shoot myself. Anyway, but my point is, very interesting stuff. If you're interested in this medical stuff, you have got to go there. If you don't go to any other museum in town besides the Gettysburg Museum of History, you have to go to the Seminary Ridge Museum and Education Center and go to that floor especially. They've got, all the floors are great, but that floor is my favorite floor by far. And one more before we go on. Bob Passamenti, who is, I believe, a new patron. Bob, thank you. I think I saw that you joined recently. Physician's assistant from Long Island, formerly CC/trauma ER at Stony Brook Hospital. I've heard of that. Sitting in my urgent care office while this is recording great material and so often overlooked, brings into focus the post-battle issues that are not part of the glorious fight. Well-deserved credit to the medical corps, both men and women. Thank you, gentlemen, for recording and posting and enjoying this. Thank you very much for that.
Yes,
I like that. Appreciate that.
Yeah. Go to the Facebook page, too. There's tons of
go to the Facebook page, Civil War Medicine and Surgery. We're not even done, ladies and gentlemen. I know it sounds like we're wrapping up, but that's just a middle of the road plug that I wanted to throw in there. Yeah, exactly. No, they don't pay me. I just oh no, they do.
What does that mean?
You don't, but you're on the show, so that's okay. Tell Thomas Robeson.
Mm-hmm.
You mentioned him at the top of the show.
Yes. I think he's a very interesting case. Not least because we've got some really terrific photographs of the guy, and that really adds to telling the story.
There's one of them.
Yeah. So he was Bostonian and was
That's
in
not him.
He enlisted. He graduated from Harvard in 1861, and immediately goes into the 2nd Massachusetts. That was Robert Gould Shaw. Too.
He wasn't here. He was in head of the 54th by this point.
Yeah, for a little while longer.
Yeah. Yeah. Right.
Yeah. So both of these guys were killed that month. And Robeson had already been wounded at one point during the war, and was conspicuous with his gallantry and all that kind of stuff. On the morning of July 3rd, he was part of that ill-fated and ill-considered attack out there on Spangler's Meadow. Was it 27th Indiana, I think, and the 2nd Massachusetts got the bungled orders. Now, how nobody ever swung because of that? I mean, hundreds of people were wounded and killed because of that.
But how do you separate that from all the other bungled orders or poorly conceived orders?
That's just it's right in your face, though.
Yeah, well,
I mean, who? Nobody ever said it was my fault. Did Colgrove give the order? Was it the messenger got it wrong? Mudge even said, "Are you sure that's the order?" I said, "Yeah,
murder, but it's an order."
Okay, well, that's the order.
I think you need to go back to your own article in Gettysburg magazine, and maybe the answer is as simple as these people were tired,
super sleepy. Yeah,
I think honestly, ever since we did that show, that really opened my eyes to a lot of things. Because of course, these people are exhausted. They've got to be, right? They're not getting a lot of sleep, even if they are. It's probably not quality sleep. It's short. It's
Have you noticed, as I have, when you're reading about this battle or others afterwards, how frequently you see that it actually is mentioned by the people?
Yeah,
they mention it all the time.
Yeah. Well, I'm sure that was probably the most valuable thing to them besides water. Like they probably maybe they even valued that above water. They dreamed of being able to sleep just one good night in a bed. How great that would be. Excuse me. So, okay.
For whatever reason that happened, the order came in, and he was in the skirmish line was his company, and he didn't take but a few steps. He was one of the first to be shot. He was shot in, I think it was the right hip.
Well, let's see. We have a diagram, I believe, in here. Well, here we are. That's the right hip.
The reason why I stuck on the bones there, so to speak, is because the surgeon who operated on him described what the injury was, which he could only have known from probing the wound, and he did. So he's got the bullet is coming in at the right hip, and the prominent part of the femur there is called the greater trochanter. It's facing outwards. That's your hip bone out here. Okay. That's the greater trochanter. And so the bullet is going through there, and it goes through the neck of the femur, which is the short, kind of slender section between where it goes into the pelvis and that big segment.
Okay.
So, and it goes right down the pipe of that neck, and then through the head of the femur, which is the part that articulates with the pelvis there in the acetabulum. And he didn't specifically mention the acetabulum, but that's sort of the cup that accepts the head of the femur.
Uh-huh.
The surgeon, that was McNulty from the 12th, who was the medical director of the 12th Corps.
Nick Nolte, huh?
He said that that the bullet was in the pelvis, and so I suspect that it went through the acetabulum into there.
So I just want to make sure I'm understanding this. Because like you said, we can't like 3D turn this around in all different directions, but it went into like his side.
It went in through the side, and it's going from right to left,
and like straight into the joint,
straight through the neck of the femur.
Ugh.
You see, which is really bad luck, but it's going straight through there and probably blows out the head of the femur up there too, which is the ball.
Yeah,
that you see there, just blows that out, and then probably keeps going into the pelvis through the cup that accepts.
And now inside the pelvis, there in the pelvicular cavity, as I call it,
there's stuff.
We've got the bladder, right?
Bladder.
We've got some
rectum,
bowels,
some nerves.
Rectum, damn near killed him.
Damn near killed him's right there.
Right. We got, yeah, right. You got nerves. It looks a little dangerously close to the spinal column.
Below
the
but
coccyx.
The coccyx is there, the sacrum. The
yes.
big iliac arteries, the internal iliac arteries.
Oh, yeah, arteries, right. You got arteries in there.
Veins. I think that's probably what got Robeson, too, by the way. So that's the injury, and he gets carried off out of Spangler's Meadow and then up the hill there to where there was an officer's aid station. And then they...
here we go.
Then they take him to, would have been the Bushman farm out there, the 12th Corps Hospital. And the 12th Corps medical director is the guy that takes care of him. That's McNulty. John McNulty's kind of an interesting guy too. Before the battle, Meade told Letterman, the medical director, says, you got to keep all your medical wagons back at Westminster.
Mm-hmm.
You can't get them up here
right,
because we don't want them plugging the roads, basically in case they get their ass beat again. And they learned from Chancellorsville, I got to have a clear route out of here. Back down to the Pipe Creek thing. McNulty's like, nope. They brought the medical wagons with them. And he said within a matter of hours after the end of the battle, every operation had been done that was necessary because they had everything.
Because they had it all. Yeah.
They had the wagons with the tents and the cooking equipment, all this kind of stuff. The other corps didn't have those wagons. They had their medical wagons and their instruments, but they didn't have tents.
Yeah.
So that's one of the reasons why they had to go into all of these homes and these barns and everything. McNulty's the guy that operates on Robeson, and he doesn't want to. He says it right there in the record. He says the outlook was bleak, and operating is probably not going to help. May make it worse. But Robeson was in too much pain, and he was begging for an operation. So they said, okay. And he did that operation that you were showing there, which is a resection of the top part of the femur.
Right. So
this gets back to what we were talking about at the start.
The chicken. So he basically has to remove the entire leg from the hip.
Here are the choices. He's got three choices. Do nothing, but Robeson is not letting him do nothing. And then so he's got two operative choices, which is to amputate, in which case he's got to, almost certainly he's going to have to do what we call a hip disarticulation, which is the January operation, except at the hip. Mm-hmm. Much bigger deal. Down there at the foot, when January was doing it with the pocket knife, if there were any blood vessels left, they were occluded, certainly at that point. Well, you got the big femoral artery right there, which is as big as your thumb. And you got to deal with that, and then all of the branches, the vein, all the branches, the nerves, all those kinds of things. It's why it is, even today, an above the knee amputation is a high mortality operation, but a hip disarticulation is another step up. We very rarely have to do that, but that is what he would have had to have done, and obviously he doesn't want to do that if there's any chance that this guy is going to be able to survive. So he elects to do a hip resection, where he cuts the femur just below that greater trochanter, and then the rest of it is pretty much just debris, just probably scooped out.
Right, because that's all. That joint is shattered.
It's just a mess. So he probably just kind of scoops it out like you're like cleaning out a pumpkin. And then he goes a nice.
Tad, you want to react to that like it's something horrible, like you did with the chicken? No, that's okay. He's a doctor, so he gets to say something like that. Okay, I get it.
Much, yeah.
Yeah. Okay, fine. Go ahead anyway.
And he makes a nice clean cut on the femur there. Now, what might eventually happen? Maybe a pseudoarthrosis does happen, and it's a leg that he can ride a horse with. He can swing around. You know, the jogging is out for sure.
Right, kickboxing.
But you can get a sense that he doesn't want this guy to wake up with a hip disarticulation. As it happens, he doesn't wake up at all.
Wow.
I think he lived about 14 hours was the report. The date of Robeson's death is a little bit strange because the initial paperwork says it was July 4, and that seems the most likely. But then the later paperwork says the 6th, which doesn't add up because he would have, if he was operated on the 3rd, and he was operated on straight away, then he couldn't have stayed unconscious for 3 days. I think he died within it was 10 or 12 hours. So what probably happened was he had an intrapelvic vascular injury, probably not the artery because you die faster, but maybe a vein bleed. Even now, those are very dangerous wounds. pelvic fractures, like closed pelvic fractures from car crashes and stuff.
Yeah.
Very, very difficult to deal with because you can't surgically get to where the bleeding is without, there's so many things in the way.
Gutting them
and
like
then
a fish.
Not exactly the phrasing I would use, but there's so many things that are in the way. It's hard to get there is what it comes down to. So we usually treat those endovascularly using catheters. But it takes a while to get that up and running, and people die while they're waiting.
Yeah. So like the bullet goes into, like it goes through. It doesn't stop in the joint, right? It went through into
the pelvis. That's what McNulty indicated.
So, does he try to remove the bullet, or is he just doing the disarticulation? Like, is he trying to get into fixing any of the damage the bullet's done in there?
Don't know. Let me see if I can find his report here.
What do you think of this, Tad, while he's looking for the report? What do you think of all this stuff, this medical? Did you ever think you'd be doing this one day?
No.
That you would be listening to people talk about,
Would I be listening to you compare these very serious and gruesome industries to food-related things? No.
Yeah, it's a consistent theme, too.
Yeah,
I'm hungry, that's why.
I contributed to it with the pumpkin.
Didn't have breakfast.
No. It's interesting. I've thankfully never been like super squeamish or anything when it's come to this stuff. So I'm sort of looking at it more from the historical and I guess maybe a bit of the analytical thing. I mean, certainly like some of the things we talked about and some of the visuals that are there is like a little bit like, oh my gosh.
Yeah.
Like Matt, I'm kind of in agreement with you about the guy who got his eyes taken out. I don't think I could do that.
No.
But no, I think sort of just taking it all in and listening to both of you talk about it has been very intriguing and has been very, again, unexpected. No. Did I ever think I'd be doing this or listening to this? No, but that doesn't mean that it's bad.
So you had dreams of Hollywood stardom and fame as a director, and this is so much better.
This just means that when I get there, it's going to be very realistic, and I'm going to attribute it to this conversation.
Oh, very good.
So you're going to watch it, and you're going to be like, see?
That son of a bitch. Yeah.
He paid attention to it.
I wanted to do that. I wanted to be the guy to make a movie like that.
And he is gutting him like a fish.
That was good.
Okay, go ahead. Did you find it?
I did, yeah.
Good.
So Dr. McNulty made an incision over the trochanter major, 6 inches long. So it is, if you have that picture.
Hold on. So that's 2 back. This one here?
Right. Yeah.
Okay.
So he pretty much does. That's textbook right there. So we were talking about that's from a surgical textbook from the
which one are we talking about? Figure 30 or 29?
It's the top 3 pictures.
1, 2, 3. Okay.
Yeah. The bottom one and the bottom right one are not.
That's the knee.
Yeah.
Good Lord. That's how they do that at the knee? Okay, but we're talking about the hip. Okay, let's go to the hip here. So 26, 27, 28.
Says McNulty made an incision of the trochanter major 6 inches long, passing through the wound of entrance and continued downward in the axis of the limb. He means down the femur, turning out the shattered superior extremity of the femur, just pulling it out, throwing it away, and sawed the bone just below the trochanters. That would have been where it was still intact. The fragments of the head and neck were then removed. There was more bleeding in this than in Dr. McNulty's other operations of excision of the head of the femur, yet the hemorrhage could not be called profuse. The patient survived the operation 14 hours. During this interval, he appeared to be unconscious. So it appears like he never woke up from the chloroform, which is probably merciful.
Probably lucky, yeah.
Merciful. So I found in the medical surgical history, primary excision of the hip fractures. There are 53 reported cases with 52 fatalities.
Huh. God.
53 cases, 52 fatalities.
Jeez.
Yeah.
Yep.
And you go back to the picture there, Tad.
Yeah.
I want to point out here in figure 26, very much like a chicken leg and what I would do if I wanted to get the drumstick. I'm just saying it wasn't so obscene for me to say that. Okay.
question.
Oh, by the way, so McNulty didn't want to operate. I looked up the results for the 3 different possibilities: conservative, amputation, excision at the hip joint. Excision, we just talked about, 97% mortality. Amputation had 93% mortality, but conservative management was 64% mortality. So there's a post-war documentation of it. So he didn't have those numbers at hand, but McNulty's his intuition was telling him to do the right thing, which was not to operate, but they did, and that was the end of that case.
David Brinson,
another pelvic injury. Yeah.
Yes. This one, it was interesting because he survives a very long time, right? If I'm not mistaken, I'll find his thing here. But here it is, right here. Here we go. Might as well hop over to this here, and we'll play a little bit of
Gunshot wounds with intestinal injury were typically fatal in the Civil War, but not always. Sergeant David K. Brinson, 13th Georgia Infantry, was wounded at Gettysburg on July 1st, 1863, during Gordon's brigade's assault on the Union 11th Corps north of town. A musket ball entered his left groin and traversed the pelvis, perforating his large bowel. Brinson received initial treatment at a Confederate field hospital before being captured by Union forces. Fecal matter escaped from the wound for about a week, but this spontaneously stopped. The bullet was removed, but no other surgery was performed, or an option. Brinson recovered and survived. He was paroled and discharged from the Army the following year. After the war, he received a disability pension. David Brinson died in 1899. Gunshot.
1899, he survived still.
Yeah,
that's amazing.
36 years.
That's amazing. And now, what kind of difficulties would he have had after that, or do we know that he actually did have specific difficulties?
I don't know that he did. I don't have really very good information about what his post-war life was like, but the injury appears to have healed itself. He was very, very lucky, obviously, to get a wound of the distal colon. It's probably rectal. He got that. It didn't hit apparently the bladder like it did with Chamberlain, and it's interesting that I talk about it there at the start of my highly paid narrator does about intestinal wounds being so highly fatal, and they certainly were. In fact, small intestine wounds, I don't believe there was a documented case of survival in the war where they were able to document the actual anatomy of a penetrating injury of the small bowel. But a surprising number of colon injuries did survive. And interestingly, these guys, these sawbones type guys, could detect the anatomic characteristics of survival versus non-survival getting shot in the colon, okay? Penetrating wound. And they correctly observed that if a wound, let's talk about the colon, shall we?
Sure. Yeah. Well, because actually, yes, because colon, rectum, all that. Damnation. Intestine, small intestine, large intestine. It's very complicated, it sounds like. And I never actually learned what the difference is.
All right.
Between
since you're hungry already, this should really help.
I hope you're not eating lunch, ladies and gentlemen.
Okay, if you're a particle of food, for example, after you pass through the stomach, you go into the first part of the small intestine called the duodenum, and then you go through the rest of it, the jejunum, and then the ileum. And that's the chitlins, if you will.
Okay.
You know, that's the small
bowel. That's what they would use for chitlins.
30 feet of it if you stretch it all out.
God.
And that's where all the digestion really takes place.
Okay.
You know? In the stomach, the food gets mixed up and gets partly sterilized by the acids, and that's one of the reasons why that's there.
Okay.
Then it gets dumped down into the intestine where the nutrients are absorbed. And then in the colon, a lot of water gets absorbed and the stool gets formed, of course, what's in there, and various other physiologic things. So
wait,
but anatomically,
I'm sorry. Where's the large intestine?
that's the colon.
That's
colon
the colon.
is the large intestine. Yeah.
Interesting.
And,
okay.
And there are subsections of that. Okay. Right where the small intestine becomes the large intestine. It's a dramatic difference between the two. That's called the cecum. And right there is where the appendix is, by the way. So it's right lower quadrant here.
Okay.
So now you got the small bowel is all sort of in here. The large bowel starts right there where the appendix is at the cecum, and it comes up. We call this the ascending colon because it's going up. You get to the liver here, and we call that the hepatic flexure because it takes a right turn, flexes. And then this is called the transverse colon. It's coming across here. Then we get to the spleen over there, and it takes a dive down this way to become the descending colon. That's called the splenic flexure because it's at the spleen.
Oh, okay.
And then down in here is the sigmoid colon, which is called because it looks kind of like an S.
I've heard of that one.
Where it takes it's down all the way in your pelvis, but then it kind of comes up, takes a little S turn, and then comes down, and then you get to the rectum, which is down deep in the pelvis there. So those are all the segments of the large bowel. What these guys amazingly were able to figure out is if you got shot in your transverse colon, curtains.
Mm-hmm.
Transverse colon's up here, the stomach's right behind it, the pancreas, the liver, all these things are in there, the aorta. If you got shot in the transverse colon, that was curtains, not survivable. If you were shot in the colon in the ascending or descending portions, it was actually more survivable, or down in the rectum was more survivable. And the reason is that a hole in the transverse colon here, even if you don't hit the pancreas, you don't hit the stomach or anything, a hole in the transverse colon is inside the abdominal cavity. That's what we sometimes call the peritoneal cavity. It's inside of that. So a hole in there is going to dump stuff out into the abdominal cavity, peritonitis.
Got it.
Infection, peritonitis, death, nasty one.
And is that because at that point there's more bacteria up there to break everything down?
There is a lot more bacteria than there is back in the small intestine, but there's bacteria throughout the whole GI tract. But there's a ton of it certainly in the colon doing stuff.
Yeah.
Symbiotic stuff. But the reason why the transverse colon was more fatal than the ascending and the descending ones is because the ascending and descending colon are actually behind the abdominal cavity. They're not inside of it. They're what we call retroperitoneal. So if you got a hole in that and it doesn't go into the abdominal cavity, the fecal matter, like in Brinson's case, can come out here. It doesn't go into the abdominal cavity, potentially anyway. So sometimes they saw people survive these wounds where the colon is not intra-abdominal. You see what I mean?
Yes.
And so those were observed to be potentially survivable injuries. And Brinson is an example of that. So his colon took a hole in it. That doesn't mean it usually happened. No.
Right.
Typically speaking, that would
dead.
Not be. They would not survive it. But the potential was there. It would be like having a colostomy.
Okay.
See, you've got colostomy by mini ball.
Yeah. Okay.
Which would be a great name for your first movie, Ted.
Write that down.
Writing that down.
Colostomy by mini ball. It's your first Civil War movie. It'll be about the Civil War doctors and all the weird cases they've had to deal with.
Well, I'll give you a cameo in it. Don't worry.
Thanks. Let me be the patient.
Yeah. Netflix and notes.
Okay. So it's not when you say it's not in the no, that's not the word. It's not perineum.
Peritoneum.
Yeah. It's a different part of the body. Peritoneum.
Funny that you wouldn't be familiar with it, though.
It's not in that sac.
It's not in the cavity.
The cavity.
Yeah.
Okay.
It's behind it. Yeah. Where the kidneys are behind that too.
Yeah.
They're not inside of that what we call potential space where the chitlins all are and the stomach's hanging in the transverse colon. So if we call extravasation is where the stuff comes out of the tube where it belongs. If it extravasates outside but not inside, then you might make it.
Right.
You see?
Right.
And then we have, like in Brinson's case, spontaneous closure after a while, a week or so, the hole heals over. And then you're basically back to normal. Like when we take down a colostomy, when you don't need it anymore,
right?
You'd surgically take it down.
So are they not, because he's got he's leaking fecal matter. They're not feeding him, are they? Like during that time, like
yeah, they probably were feeding him. Yeah.
So they're making more. That sounds.
You got to feed the guy. Yeah.
You got to feed the guy, but like it sounds like it would be dangerous to do that.
Well, even if you don't eat, you're still going to make fecal material just from the lining and the
yeah.
So just taking nothing by mouth does not mean that you're not going to.
So might as well smoke them if you got them. Yeah. Okay. That's amazing though. So he survived no infection?
Yeah, apparently not. No.
That's amazing.
And I think it's key that, and this is sort of a theme with the penetration of these structures, is if there is a avenue of egress, but nothing into one of the body cavities, you might make it, and it may or may not eventually heal over, because some of them were persistent. They call them stercoral fistulas. And they would last for years or maybe forever afterwards. And then it really is like he's basically got a colostomy.
Yeah.
But sometimes they would spontaneously heal over. But the problem, of course, was if there was also a hole in the abdominal cavity, that doesn't matter. You're still going to die of peritonitis because you got stuff getting in there. The same thing was with the lungs. There was another case that I need to post. That was a guy called what the heck was his name? Breedlow. He was at the Brickyard fight, and he got a pelvic wound like Brinson's that also healed up, but he also got hit in the chest, and he had the classic sort of sucking chest wound that you'll hear about, open pneumothorax, and he had what we would call a bronchopleural-cutaneous fistula, which is a hole between the airway, the lining of the thorax, and the skin. And he lived with that for decades afterwards.
Yeah. I'm sorry. I'm looking for something that I want to make you. Yeah. So
that's an example of the same kind of thing with Brinson, except in the chest, you see.
Pelvic wounds. I'm trying to find Gettysburg by the numbers. I always have it right here, but somebody must have taken it. Maybe the cleaning lady moved it. Gettysburg by the numbers you have that book? It's a little book. It's a great book to have in your pocket or on your desk when you're doing your podcast until it goes missing.
Is it on the bookshelf?
I don't know who would have put it there.
Is it?
No. It's a small white book. Anyway, I guess that I could just speak in a general sense. There's a page there about wounds. And if I'm not mistaken, this is why I was looking up the book. If I'm not mistaken, hip wounds on the left side were the most common. Have you heard that? Can you think about it? The way they're standing in line, their left hip is
it makes sense.
Pointing towards the enemy.
Yeah, it makes sense.
I wanted to get the actual numbers on that, but so because there are a lot of hip wounds that we're talking about here, and the most famous, one of the most famous ones, of course, you got Hancock here at Gettysburg with a hip wound, groin. And when they say groin, everybody thinks the privates, right?
Yeah,
but like
unless you're in the medical field, then you don't.
That's what I'm saying. Yeah. What are they talking about when they say groin?
Groin, or as one of my nurses used to pronounce it, the groin.
The groin.
Don't we all wish?
Speak for yourself.
The groin is more of the
Pad's got the shrinking.
What we call the inguinal region is the area lateral. It's off to the side of the private partage area.
Right.
You've got some important structures there: the femoral artery, the femoral vein. There's the femoral nerve, all in that groinal area. There. So
the crotchal region.
That is it. Yeah. It's just outside on the left and on the right of the crotchal region
of the genitals.
Defined. Yes.
The genitals are in the groin, but they are not the groin.
No.
Right.
Not the groin. Yeah.
The groin is that whole.
I think of it. I personally think of the groinal region as being right here. So Hancock was hitting the groinal.
Yeah. So in other words, like to the right, to the left of the genitals
of the package.
Right. Of the pack.
We're talking about soldiers here. Almost all of them are.
Yeah. I mean, they can handle it. Okay. So that's interesting because until really very recently, is probably talking about the Hancock wound and how they call it the groin. But from what I've read, it's not anywhere. No, I shouldn't say anywhere near, but it's not right in the crotch.
No, it was not hit in the as we call it in the medical field, the junk.
Right, the junk in the medical field. But my point is that's where I started to put two and two together in that, well, maybe to doctors, the groin is something different. And I just keep forgetting to ask. So this is the first time I remembered. But aside from Hancock, one of the more famous pelvical wounds is Joshua Lawrence Chamberlain. Doesn't receive it here at Gettysburg. He receives it later at Petersburg, right?
Petersburg.
And this wound has fascinated me ever since I heard about it. Walk us through it, if you will.
Okay. Well, the story is that he was leading his troops in an attack on, I think, the 18th, June 18th, something like that, 1864, and it was an attack he didn't necessarily want to make, although he was a super aggressive guy. And as he was turning back to see if his men were following him, he took a hit in the right hip. He was waving his sword and he put it down into the ground to keep himself up because he didn't want to fall down in front of the men. So he stayed up long enough for them to pass him, and then he collapses down there and is bleeding profusely. He said his quip was, "I'm not of the blood of Virginia, but Virginia is of the blood of me."
Yeah.
So you can guess that he probably bled a lot. Was eventually found, I think somebody saw the glint of his sword or something through field glasses. It's a little bit hazy in my memory. Anyway, he was found. He was brought back to the division hospital of the 5th Corps. And the surgeon said, "Nah, I can't do anything for you." He would have seen. So now you're looking at a hole here. And I believe the bullet was extracted at the time of the operation. It was over on his left side and basically buttock.
Under the skin?
Under the skin, yeah. So he would have
entered right side of the hip, travels across.
Yeah, I've got the actual anatomic description of that one.
Is it on your Facebook page?
It might be. I put it on pretty early.
All right, I'll go search it. Oh, here it is. Man, that was quick. All right, here's, of course, we know Joshua Chamberlain. There he is. Here's, okay, there you go. Okay, this is what we're talking about here. So, okay.
Here, the ball entered the right hip in front of and a little below the right trochanter major, which we talked about before, passed diagonally backward and made exit above and posteriorly to the left great trochanter. I don't think it actually did make an exit. The bladder was involved in the wound at some portion, as the subsequent history of escape of urine from the track of the wound and its extravasation testified. So that was actually the report of his pension examiner from 1873.
This is the actual bullet that was surgically extracted from Chamberlain.
Yeah, They've got that up at the museum.
God,
in
look
Maine.
at that. See, and that's the thing for people who are new to all this. That's the problem with a wound in the Civil War. The bullets were soft lead and they deform when they hit the body. And look at that. Look at that. That's an ugly looking
missile.
Yeah. And then we'll go back over here. Okay, so the bladder, it nicks the urethra, or
I tried to make a drawing of
great
the soft tissues too, which may be more difficult.
I'm going to cover this part with my fingers. No, we're all adults here, okay?
Yeah,
here we go.
This is YouTube.
Oh, YouTube can kiss it.
Okay.
Okay. So I don't know how clearly that's coming in for everybody there, but this is the best we can do. Maybe in post.
It's a little bit of surmise on my part. This is what we think based on the description, and I showed you the bony thing to give you a sort of an overview. But the path of that is appropriate, I think, because it takes into account injury to the urethra and to the bladder there. And that, I think, is the consensus of what the injury was that he had.
Okay.
He does not appear, I don't see any good documentation for any bony injury, which would be unlikely, but possible that it was only soft tissue. But if there was a bony injury, the report doesn't mention it.
So it looks like, so in other words, you're saying it just went through all the fleshy parts of
bits.
This area, which I guess he's lucky in that sense, except for the fact that the rest of his life he's leaking urine.
Also very lucky that he didn't hit one of those major vessels that we talked about and go through the pelvis, which would be the thing I would be thinking about as a vascular surgeon. But, so yes, he sat there. The divisional surgeon says, not going to touch you. He would have seen, as we see, that there's urine coming out through the wound, and that's means that the bladder's been damaged, and there's nothing he's got that's going to help.
Yeah.
There's nothing he can do about that. So he pronounced the wound mortal. And then Tom Chamberlain shows up, and I forget the name of the actor that played him.
C. Thomas Howell.
Yeah, C. Thomas Howell shows up. And he's got the surgeon from the 20th Maine with him, and also the surgeon from the 44th New York.
Right.
They heard that his brother was wounded, so they apparently don't trust the 5th Corps docs or whatever. They show up, and they say, we're going to try and do something. We don't know what, but we're going to try and do it. They give him chloroform, and it seems like he may have been partially anesthetized, because Chamberlain afterwards, and you got to take what he recollects with a grain of salt, I think maybe in general, but particularly with regard to this, because we know he was anesthetized. But he talks about feeling pain that was so severe that he could not have imagined that anyone could tolerate it and still live at that time. So what I think that they did, the evidence is pretty clear, is they explored that wound, they got the bullet, found the bullet, got it out. Because remember, that's, even though we wouldn't necessarily look at that as being something that absolutely has to take place, they put it right at the top of their priority list surgically. Got to get the bullet out. They did that, and then we know that afterwards he had a catheter in. So what I think they did was they put one of these guys into him.
This reminds me of an episode of Deadwood. Okay. Here we go. They put, when you say into him, you mean gone through the head of the penile.
Yes, that would have gone through there. And then through the wound.
And by the way, this isn't to scale.
I think it's pretty close, actually.
No way.
Yeah, I think it's pretty close. No. The diameter may be, which is your issue. The diameter might be exaggerated there.
Oh, God.
But I think it's probably not that far off. So anyway, those surgeons would have guided where that catheter was going to make sure that it got into the bladder. And then they would have known they were successful, because urine would have come out through the catheter, not through the wound, you see.
Yes, because so the urethra it's nicked. It's not severed, correct?
I think. I don't know. They didn't mention it in that kind of detail. It would have been also.
I mean, if it's severed,
you would have to reconstruct it surgically. Yeah.
Right. And how are they doing that back then?
Not even thinking about it, though.
So it has to be.
It must have been mainly intact. Yeah.
Yeah. This is basically bridging that gap. It's not a gap, but it's closing the hole in the urethra so that urine can flow through the proper way.
I will go even so far as to say I'm not completely convinced that the urethra was injured at this time. It may have been just the bladder. Okay. And here's what I'm talking about. They would have put the catheter in there whether there was a urethral injury or not. So let's just say there's a bladder injury only. The catheter gets put in there to drain the bladder of the urine so it doesn't come out through the wound. You still don't think it's very likely that he's going to survive, because you don't know what else has been injured. You don't know if the bladder injury is going to repair itself or not. Mm-hmm. Okay, because they would not have had any techniques for repairing the bladder injury at that time. And now let's also remember, you're at a field hospital. There's none of this was done sterilely. It was done with field hands in the wound, guiding this and all. So the reason why I'm not convinced that the urethral injury happened at the time of the wounding is because the pension surgeon who talks about the urethral injury afterward blamed it not on the wound, but on the catheter.
Okay.
Specifically, here's what he says.
What is, in other words, saying that the catheter did damage?
Right. So let's back up just a little bit. in 1864, the treating surgeon, after he gets carried to City Point, Chamberlain gets taken to Annapolis, where the surgeon there, a guy called Vanderkieft, takes care of him. Vanderkieft sends to J.H. Brinton, who's running the War Museum under Hammond, he sends him that catheter. And if you look at it, the catheter at the end of it has all these deposits on it.
Yes, I noticed that.
Yep.
That looked particularly uncomfortable. So that's not by design.
No.
We're talking about here, there it looks like calcium deposits, which is kind of hard to see, I think, in the camera. But
Yep.
Okay.
And that catheter had been in place for several days. And the surgeon at that time was concerned about this. In fact, when he sends it, he says, I send you a catheter used by Chamberlain. As you will perceive, it is covered by a calculus deposit. This catheter was but 5 days in the bladder and was repeatedly covered in the same way. I think it is a very important specimen illustrating the necessity of often renewing catheters, changing them. So then, that was in 1864, but in 1873, the pension examiner who was examining Chamberlain at that point says, the chief disability resulting indirectly from the wound is the existence of a fistulous opening of the urethra, half an inch or more in length, just anterior to the scrotum. This often becomes inflamed. The greater part of the urine is voided through the fistula itself resulting from the too long or too continuous wearing of a catheter. So,
now, fistula is an opening?
A fistula is an abnormal communication between two epithelial surfaces. That's the
course.
Then let me unpack that.
Please do.
Epithelial surfaces are things like the skin, the lining, the mucous membranes, the lining of the intestine, the lining of the lungs. These are also epithelial. That comes from the embryology. But if there's a normal anatomic connection, your mouth is, your nose, your ear. These are normal anatomic connections between epithelial surfaces. An abnormal one that's been created by a surgeon or by trauma, is called a fistula, or by other disease processes.
So like if I have a hole in the roof of my mouth that goes up into my sinuses.
Fistula. Or you've got, we've been talking about these intestinal wounds, where they're draining. If a wound is draining fecal matter, that's a fistula, going from the colon to the skin or from the small bowel to the skin.
Got it.
Those are fistulas. So a urine draining out through non-anatomic purposes, non-anatomic pattern
channels.
is a fistula.
So read that again then, so that I have that
on the bottom. He's got it. It's
just about
fistulous opening of the urethra, half an inch or more in length, just anterior to the scrotum. So it's right on the bottom of his penis, right on the bottom, just in front of the scrotum, half an inch, and most of his urine is coming through that.
And so, in other words, then that was created by the bullet?
No, that was created by the catheter.
But they weren't putting the catheter in there. They were putting the catheter in through the end of the urethra.
Right, but the catheter is sitting in there, and as it's sitting in there, it's eroding the urethra,
right,
digging through it, it's scraping it, and eventually it eats a hole through it and creates a fistula.
So it's like a cyst fills up with fluid, and it needs to find a way out, and it creates a sinus and a head on the surface of the skin where it drains. Is that similar?
You're bumping around.
I'm sorry.
But picture that you've got a channel, use your words, good word,
Thank you.
A tube, a channel right there, and then it's separated from the skin by all this tissue right here, right? But you've got a catheter that's made of wood or metal.
Oh, I thought those were metal. Okay.
Could be metal, could be wood, could be gutta percha. It's in there, so it's not like these flexible silastic things that we have now that are can't do that with that. So it's a rigid thing, and all it takes is a little bit of back and forth, and you've rubbed a hole in the urethra. The hole eventually sneaks out through the bottom of John Henry there, and now you've got a fistula, and it's a half inch. That's not closing up on its own.
Right.
He had at least 4 operations that we know of after the war, probably trying to close it. So no, the fistula was not caused by the bullet. It was caused by the treatment. But the catheter that they put in at the first operation did save his life.
Yeah.
And he lived 50 more years.
Now, while he's living those 50 years, he's he's got no control over retaining the urine, right? Like he can't hold it.
Yeah, it's below the place where you are able to do the holding.
Right.
Yeah.
So it's just
Probably.
constantly leaking out.
Very, very likely, yeah.
Now
I don't know that for a fact because I don't know exactly where, if the urethral sphincter was involved or not. I don't know for a fact that.
Okay.
And we don't have, nobody wrote it down, so we don't know that.
Which
But
would be the
certainly
thing that would make you able to hold it.
Yeah, he may have had some limited ability of that. I'm not a urologist.
Okay.
But we don't have any information about whether he had constant drainage or not.
You know,
I
for
think
all
that
the
probably
things,
the answer is yes.
for all the things that people say about Chamberlain, right? Oh, he's self-aggrandizing and, all this stuff. And a lot of the times, all the time, for the most part, he's writing all that stuff while he's leaking urine, perhaps, right?
Yeah.
Let him self-aggrandize. You know what? I have what am I trying to say? A larger amount of respect for this guy after hearing this stuff, because he lived to what? How old was he? Like 90? 84.
Yeah.
Yeah. 84 years old. He was 30 something during the Civil War.
Oh,
damn.
Okay. So that's what? 50, 80, 90, 20. It's like almost 100 years of living since it's 50 years.
Maths are hard.
50 years.
Lived 50 years. Yeah.
Don't
forget the infections, because he had ongoing recurrent urinary tract infections too. In fact, that's what eventually killed him.
Yeah.
Too. And in reality, actually, somebody mentioned this in the comments when I posted that case, that the first surgeon was right. It was a mortal wound. It took 50 years.
50 years, yeah.
Because he died of urosepsis. He died of urinary tract.
But that pain, though, not only the pain of like the infections and everything, but again, I'm going back to the humiliation factor. Like you're walking around in public. There's pictures of him as an old white-haired man on horseback.
That poor horse.
Yes, the poor horse, covered in urine and sweat.
Old Yeller.
I thought we gave you a white horse, Colonel. General, excuse me. So my hat's off to him, man. Any of these guys that can, go out in public with these horrible, ghastly wounds, embarrassing wounds, things like that. And that has got to be one of the worst, like just constantly. I mean, let's say he could hold it. Let's say it didn't hurt his, what was it? Urethral sphincter?
His sphincter mechanism.
Yes. Let's say it didn't hurt that, right? I would imagine the catheter use. Like, was he still using a catheter late into life, or was this just this thing? Are they shoving this in there early on, or is this something he has to use his whole life?
That doesn't seem like like he did, because it says the fistulous opening, greater part of the urine is voided through the fistula. So fistula, so that was in 1873. So by 1873, it seems like he wasn't wearing a catheter anymore.
So, but he is leaking urine through this fistula.
Through the fistula, yeah. Not all of it. Not all. It says the greater part.
But the greater part sounds like might as well be all of it.
Yeah.
Right?
And he was getting $30 a month, by the way.
God.
And they considered him total disability too, by the way. Went on to be governor.
Yeah.
President of the university.
Remarkable people these guys were, to be able to suffer this stuff and go on about life and do things,
accomplish things
of value to society later on. And I mean, they do that to this day. I'm not saying that this is a unique generation, but maybe they were, because the medical care that they had was nothing like what we have today. And these guys were going out and about doing all these different things, and with these just horrible wounds.
Not much in terms of social safety nets.
No.
For veterans.
No.
It's nothing.
I mean, $30 a month was not anything to sneeze at back then, but still, that wasn't enough.
Yeah. I think $6 was the standard.
The average income.
Yeah. No, $6 was the standard pension.
Oh.
If you were just sort of garden variety without. it was a sliding scale. So depending on whether you'd been wounded or not and the severity of the wound, like a hand would get you a certain amount of dollars.
You could still do a lot of stuff. Yeah. Did you ever watch Deadwood?
Yes, I remember Deadwood. Swearingen.
Yeah, Swearingen. Do you remember there's an episode called Requiem for a Gleet? Are you familiar with this episode?
Is that the one where Swearingen has a stone or something?
Yeah, he's got kidney stones.
Yeah,
and it's blocked him.
That.
And he's backed up with urine.
Yeah, he's going to die.
It's such a great it's like a 2-episode story arc.
Yeah.
But they have to the doc sticks a catheter like this up there to free up the flow of urine. Mm-hmm. And they do it really well. I mean, I don't know if it's medically accurate. I imagine it is.
Probably, yeah.
I don't know. I don't know. It just seems a little too. For some reason, smelling salts saved the day, and I don't know how they got to that. It was just, I don't know. But I mean, they do it well in the sense that when it goes up, and they don't show it obviously, but when it goes up there, you hear tink, tink, tink. You hear like the stone tinking against the probe, and then of course it leaks all over the floor. It's disgusting. But I've had a kidney stone. That's a terrible pain. And it just passed naturally. I didn't have any problems with it or anything. But like while it's making its way down there, that doesn't feel good at all. Mm-hmm. Terrible pain. And I just can't imagine where it's to the point where, especially back in those days, where you can't. What do they do today? They like zap it now. Right, they break it up and
they can. Yeah, I mean, usually they'll pass on their own. You give them hydration and try and get a lot of water in there so that there's something to flush it through. But
you know what somebody told me once, and this was an anesthesiologist who said she heard it from a urologist. So I believed it, and I did it, and it worked. This is when I had my kidney stone. I was in my 20s. You're broke. I didn't have insurance, anything like that. So I never went to doctors. And I'm like, I don't have the money for this. Like, what is this? It's a terrible pain. I thought it was cancer. It's always cancer. And so I go to my friend's wife and I go, hey, this is what it is. Like, what do you think it is? And she's like, it sounds like a kidney stone. And I go, okay, I could live with that. And I go, like, what do I expect? And she's like, well, I don't know. We don't know how big it is or anything like that. And since you don't have insurance, here's what a urologist told me to do. And I said, oh, okay. She goes, go get a 6-pack of beer. Drink as many, but not all, as you can in an hour. And she's like, the alcohol will relax you and the rest of the beer will make all that urine. And if it's going to work, if it's passable, you're going to pass
down the river. Right?
Yeah. And by the next morning, I felt fine. It did it. And I was like, man, if I ever get a kidney stone again, I'm getting hammered. Like, I know exactly what to do. But I was like,
don't put the lemon in it.
Right? There you go, full circle.
But that was a week though that I was walking around with that before she told me that, and then in one night, gone. Great stuff.
All right, public service announcement.
Yeah, really. Don't take it from me. This is fascinating stuff. I love this. I love that you made this Facebook page. When did you make it?
Right after Christmas.
Yeah, so you've got really good traction so far. I mean, I'm looking at some of these videos. They're like 1,000 likes.
Yeah, just for whatever reason. The Yule one. Yep. The Yule one got 250,000 views.
Yeah.
I mean, I just couldn't believe it.
That's great.
It's wonderful that people are so fascinated by these things, as you and I are,
Yeah. Addressing Gettysburg's been around since 2010, the Facebook page, and we don't get anything like that. Of course, I don't do anything with it, so that's probably why. But
see, it's the introspection part that...
Yeah. Start feeling sorry for myself, and then I realized it's all in my own hands. Like, nobody's picking on me. I could certainly make it work better for me if I just worked. Thanks for coming in, Craig. I always appreciate seeing you. And I hope you enjoyed this, ladies and gentlemen. I love this stuff. I'll do 1 million medical episodes, whether you like them or not. I just love them. I really do. I think they're a lot of fun to do. Somebody says, can you ask about John Chase?
Oh, Chase was the artilleryman with 48 wounds or something.
He hit 1 million times.
Yeah.
Left for dead.
Yeah, I'm going to do a thing on the page about Chase, because I saw a photograph of him. It was interesting. You always see the woodcuts, I saw a photograph of him. Might have been in an old Military Images magazine. If you're into those old Civil War pictures, Military Images is amazing.
Yeah.
You can see some tremendous stuff on there. So yeah, he was the guy who had the explosion, right, when they were putting the case shot in or something over there by the 5th Maine.
Yes, I believe.
Yeah. And he had all of those wounds. Yeah, I'm gonna profile him in one of the cases going forwards.
Oh, good. So that you're just going to have to go to the Facebook page, and like it, and then you'll see that and more. Civil War medicine and surgery.
If you follow it, you don't have to.
Yeah, follow it, like it, whatever the word is. There's 2 different things, and I don't know what the difference is.
I think liking just means you like it, but if you follow it, you get all of it. You know, I mean, it just shows up in your feed. You know what I mean?
Yeah. I don't know.
Well, I follow Addressing Gettysburg, so I don't miss a thing.
The damn right. You're a patron too, aren't you?
I am.
Yeah.
Yes, sir.
So I take that back before I said you aren't paying. You are paying.
Pay to play.
You don't have to be a guest, but it certainly helps. It certainly bumps you to the top of the list. Tab, what were you saying?
Oh, I was just trying to plug the Facebook before you did. So
thanks.
Yeah.
Thanks a lot.
I got you.
As an EMT, I love to listen and learn about Civil War medicine. That's what Harry says, so that's good. And then Yua said, "Dear Lord, I just joined, and this is what I came into. Wrecked him, damn near killed him. I'll come back later. Oof, too much, too soon." Very good. All right, listen, ladies and gentlemen. I appreciate you listening. Thank you very much for listening. If you're watching on YouTube, don't forget to like, share, and subscribe. Also, you can hype now. I don't know what that means,
You can hype,
but hype it. It sounds like it might help bust the algorithm.
Yeah.
Because the algorithm, once January came, screwiness again. They change it. Oh, God. YouTube is the worst. They don't let you just let the free market decide, right? Like they interfere.
They test it and stuff, right?
Yeah, they interfere with things, and it's very annoying and very frustrating. But they say, just keep on going. Keep on going. Shut up. Craig Miller, thank you very much for coming on. Dr. Craig Miller, that is. And Tad, once again, thank you for the wonderful job back there on the cameras. And ladies and gentlemen, patrons, thanks for watching and contributing to the comment section. And to the rest of you, thank you very much for watching. We'll talk to you next time. Bye. All right.
Fun.